Right. Is everyone here? Okay, so welcome to the last class, the last topic and the last class today for this module, right? Guys, turn your cameras on. Let me see your faces. I see only 2 cameras turned on. Hmm. Right. Let me. Okay. So Sjogren syndrome. Some people pronounce it with the S silent, right? Sjogrens, pronounce it however you all want, doesn't matter, right? The important thing is to understand the disease and the concept. Now, what do you all know about Sjogrens, guys? Anything about Sjogrens? Anything? Before we dive into this topic, anything? What do you all know about Sjogrens? Don't read the notes, right? Anything we have talked about from the past classes? Anything?
Autoimmune.
Autoimmune, okay. Okay. Anything else?
Antibodies against salivary glands.
Antibodies against salivary glands. Okay. Okay. Good. 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 Did we mention anything? Did we mention anything about Sjogren's or any relationship when we talked about SLE? Do you all remember anything?
And antila.
Yes, the anti-Rho and the anti-La, right? It can be positive, right? We talked about during SLE as well, right? So we will talk more about those things, right? Give me a second, guys. Let me share the screen. Take your skeletal notes out, guys. We'll just go through the introduction part first, right? Okay. A second. Right. Look at this, guys. So Sjogren syndrome. Look at this. A systemic chronic autoimmune disorder of unknown etiology, mainly affecting exocrine glands, guys. Now, just like the name says, right, you all know we have this topic is this chapter is this module is rheumatology, right? So we are discussing these connective tissue disorders. Sjogren's is also one of these autoimmune connective tissue disorders. Now, this was first why what is the Sjogren, guys? What does the word Sjogren mean? Anyone? What does the word Sjogren mean? It's the person who found it, right? It's the person who found it. So his name was Henrik Sjogren. So he found, apparently he was an ophthalmologist. So now what he noticed was, so when he were, most of his patients, some patients that came to him, he noticed they complained of dry eye, right? Dry eye. And those very same patients also complained of certain symptoms like dry mouth, arthritis, right? Things like that. So what he did was he noted these patients' recordings down, right? Henrik Sjogren, he noted these down, and only later, right, years later, right, scientists also came across this, and they were like, Sjogren has found this out first, right? He has noticed this first, so they started calling it Sjogren syndrome. Right. So mainly affecting the exocrine glands, right? Why we say mainly, guys? Why we say mainly? We will see there is something, we are going to look at something called extraglandular manifestations, right? So mainly this disease is affecting exocrine glands, but there are extraglandular manifestations as well. We'll talk about those. Again, like with all autoimmune conditions, female predominance, right? Again here, guys, ratio is 9:1, just like SLE, right? Female predominant, right? Then classification, guys. Now look at this. We have something called primary Sjogren syndrome and secondary Sjogren syndrome, right? Primary means just Sjogren's in itself, right? Purely the patient has only Sjogren's manifestations, no other thing, nothing else. Secondary Sjogren's, guys, is associated with other rheumatic conditions, right? It can be SLE, it can be scleroderma, rheumatoid arthritis, whatever, right? The patient has another associated disease, a rheumatic condition. Now this classification, guys, slowly it is going out of style. This is, we are not using this little by little. Still some books you might find, but little by little in the newer editions they are removing this. Why? Because the secondary Sjogren's, initially what they thought was there is a disease, right? There is a rheumatic disease, and because of that disease the patient develops Sjogren's. That's how this secondary Sjogren's name came. But now what we know is, let's say we have a patient who is having SLE and Sjogren's. Now what we know is, guys, even with extensive history, even with testing, we cannot figure out which one came first. Did the Sjogren's come first and give rise to SLE, or did the SLE come first and give rise to Sjogren's? Right? So we cannot figure this out easily. So now, little by little, this classification is going out of style. But still, for your exam purposes, they might require this from you these days, right? Maybe in the near future, this will be gone, right? And then, guys, just write down, right? Because again, in some questions, these words come, right? This Sjogren syndrome is also called Sitka syndrome, right? Sitka syndrome, same thing. Sitka means what? Sitka, the word Sitka means dry, guys, right? Okay. The word Sitka means dry. Okay. Sitka syndrome, same thing, because in some questions you get these words. It's the same thing. So don't get confused, right? Right. Then we will come to the pathophysiology, guys. Pathophysiology, right? Let's take a new page. Look at this. Pathophysiology. What is happening in this disease, right? Right. What I want you all to understand, guys, first we will have a look through the general mechanism, what is happening, and then we will go into depth, right? What we are going to see is there are certain risk factors, guys. We will talk about what these are, right? There are certain risk factors, right? These risk factors, guys, right? They are going to do two things. One is lymphocytes, specifically T lymphocytes, guys. T lymphocyte, right? T lymphocyte infiltrations will be there. T lymphocyte infiltration, don't worry, I will teach what this is, how this is happening, what is going on, we'll talk about. The other one I want you all to know, guys, because of the risk of these risk factors and the damage coming in, there is going to be B cell hyperactivity. Okay? T lymphocyte infiltrations, B lymphocyte hyperactivity, right? This T lymphocyte, guys, when they infiltrate an organ, right, we call this a cell-mediated immune response. Right? Whereas B cells, we know B cells, they mature into plasma cells and they start producing antibodies. So here it is an antigen-antibody mediated response, right? Antigen-antibody mediated response, right? Both of these, guys, both of these together give rise to inflammation and damage, right? Inflammation and induces cellular destruction, which we'll talk about. Okay. This is the hallmark of Sjogren's, guys. What is the hallmark? There is both a cell-mediated mechanism and an antigen-antibody mediated mechanism going on in Sjogren's, right? Sjogren's. Okay. This is characteristic for Sjogren's. Okay. Now, what I want you all to know, inflammation and damage, right? Inflammation and this damage. Where is this going to happen, guys? First thing, primarily in the exocrine glands. Okay, exocrine glands. And then we can also have it systemically spreading to other parts. Systemic, right? Systemic disease and exocrine glands. When it is occurring in the glands, guys, we are going to get a specific set of manifestations which we call glandular manifestations. Okay. And when it is systemic, we are going to get these extraglandular manifestations. Extraglandular manifestations. Okay, glandular manifestations and extraglandular manifestations, right? So this is the basic mechanism of what's going on here in Sjogren's, guys. What's going on here in Sjogren's. Now we will dive deep and we will see what is actually happening, right? So we'll start off from this end, right? Risk factors. Are you done writing? Right. Guys, turn your cameras on. Let me see your faces. Only like 5 cameras are turned on. Right. So let's start off with the risk factors, guys. Okay, risk factors. What are these risk factors? What are these risk factors? Look at this, guys. The first one, we'll divide this into several groups. First one is, guys, genetic risk factors. Genetic risk factors. Genetic risk factors. Right? Here, again, like similar, but we have some exceptions. We'll look at it. The first one is, guys, the first one I want you all to know, right? HLA gene mutations. Right? HLA gene mutations. HLA codes for what? HLA codes for what? MHC molecules. MHC molecules. Right now, I think throughout this module, we've talked about this several hundred times. Look at this. What I want to say is, guys, look at this. There are some specific ones. I do not want you all to memorize these, but I will tell you all the point to understand. I will tell you. Just write this down. HLA, guys, specifically, they have found several, right? One is HLA DRW52. This is the major one. This is the major one, right? Don't worry. I do not want you all to memorize this. I will tell you all what to get from here. Write this down. Then another one is HLA-DR3. HLA-DR3. This fellow is the notorious one. We have seen him in a lot of these, including most of these connective tissue disorders. Then, guys, there is this other important one. Write this down. HLA-B8. Right? HLA-B8. Right? Look at this. These HLA-DRs in general, what do they code for? What exactly do they code for? MHC1 or 2? MHC2. Excellent. We know this. We have talked about in the previous chapters as well. MHC2. When you see DR, right, it's about 2. MHC class 2. MHC-B8, guys. This one was relatively recently found. Relatively a little bit recent. This one we know they code for MHC class 1, right? MHC class 1, right? Now, nevertheless, what I want you all to understand, these two are the major players, guys. These two are the major players. Major players. What do I mean by these two are the major players? When we take a biopsy and when we look at through the microscope, right? When we look through the microscope, how Sjogren's will show is mainly an issue with MHC class 2 molecule related mechanisms. So we are talking about CD4 plus mechanisms, right? So majority you will see MHC2 issue giving rise to this pathophysiology. But this recently what we have found out is, guys, MHC1 also plays a part, right? MHC1 with what type of T cells does it interact and gives rise to the immune response? MHC class 1? Cytotoxic or CD8 plus T cells, right? Whereas MHC2 goes with CD4 plus, the helper T cells, right? So today we will see in the pathophysiology, right? Just I want you all to know MHC2 is the major player, right? Major issue there, right? Then, so that is regarding the HLA mutation, guys. Second one is STAT4 polymorphism. This is the same thing we talked about, right? In SLE. What is happening with STAT4 polymorphism? Anyone remembers? What is happening? We talked about the same thing, same mechanism here also. Nothing different. Sorry?
The TREX protein thing.
I heard protein accumulation. Is that what you said? I'm not sure. Guys, do you all remember we talked about when there is STAT4 polymorphism, we said there is a problem with interferon, right? Specifically interferon type 1, right? Interferon type 1. What did we say? Interferon type 1, right? When there are abnormalities, because interferon type 1 is essential for the MHC function. So when there are abnormalities regarding STAT4, there is going to be again MHC class 2 dysfunction, right? We talked about these in SLE. The same things apply here, guys. Same mechanisms, same mechanisms. These diseases, they have this very similar underlying mechanisms, right? So these are the main genetic ones, guys, right? HLA problems and STAT4. Out of that also, remember HLA DRs are the major players. That is MHC2. Remember MHC2 pathways. What are those? CD4 plus pathways. We'll see the pathway, but just keep that in your mind. Next one. Environmental factors. Environmental factors, right? Environmental factors. Look at this. What are we talking about here? Right? Right. Here, guys, unlike for SLE, if you all remember SLE, we had a number of environmental triggers that would come into play. Here, guys, we are talking for Sjogren's, for primary Sjogren's. When Sjogren is alone, we talk only about one environmental factor. What is this? What is this? Viral infections. Viral infections. Okay. Viral infections, guys. We'll see how this viral infection plays a role. But for now, just know, right? It can be Epstein-Barr virus, right? Cytomegalovirus, the same things that we talked about. Hepatitis C virus can play a role. And there is another one, guys. Have you all heard this one? HTLV1. Have you all heard this? Human T lymphotrophic, right? Human T lymphotrophic virus type 1, right? Lymphotrophic virus type 1, right? What disease is related with this? HTLV1. Anyone? Sorry? No, it's okay. Shashank is trying to guess. It's a little difficult to guess this one, Shashank, right? This one gives rise to adult T-cell lymphoma. Okay, adult T-cell lymphoma. Yeah, close, I know. Right? Adult T-cell lymphoma. Right? Okay. Right? It's a retrovirus. It's a retrovirus, guys. It's a retrovirus. Right? And then you can put number 3, guys. You can say others. Other risk factors. There are a few more, right? We have already discussed, guys, especially we talked about the female gender, right? Females are affected greater than males in this. So that is also a risk factor. Apart from that, guys, when you look at the age group, it is usually during midlife around 45 to 55. This is the peak, right? This is the peak age group. But just remember, it can occur in any age group. Sometimes, guys, what we have talked about, right? These certain antibodies that are present in a Sjogren's mother, right, can go to the fetus and cause neonatal forms of lupus as well. Neonatal forms of lupus, they can cause heart blocks, right? We have talked about a few of those. So it can be at any age groups, right? However, the peak is 45 to 55. Females mainly 45 to 55, right? And then just know, guys, there is a relationship with other rheumatic diseases, right? So if a patient has lupus, if a patient already has lupus, they are more likely to develop or concurrently have Sjogren's, right? Lupus, scleroderma, rheumatoid arthritis, all of these rheumatic conditions, right? Okay. Right. So these are the major risk factors, guys. The main ones, these other ones are definitely, the female sex and the age, but these external ones, the genetic and the environmental. These are the two major players here. How they say it, guys, if you look at a book, if you read through your textbooks, right? Now, I will quote from Harrison. Harrison says this. Listen to this. Y'all can write this down. Pathogenesis of Sjogren's is believed to be triggered by an environmental factor activity on an already genetically susceptible individual. Okay, write that down. Pathogenesis of Sjogren's, right? Pathogenesis of Sjogren's is believed to be triggered, right, by an environmental factor activity, right, by an environmental factor activity on an already genetically susceptible individual, right, on an already genetically susceptible individual, right? So what are they saying, right? With just the environment, with just the viral infection, you won't get Sjogren's. With just the HLA mutations and STAT4 polymorphism, you won't get Sjogren's without the viral infection. These two go hand in hand, right, to give rise to Sjogren's. That's what they want you to understand. So we will see how these two interplay with each other, right? Take a new page, guys, right? We're going to use this entire page, one full page for this pathophysiology, right? We'll start off, guys, with this viral infection, right? And then we'll see how that comes into play with the genetic problems, right? Viral infection, we'll start there. So what did we say? Sjogren's, we said, guys, it mainly affects our exocrine glands, right? So we're going to talk about lacrimal glands, we're going to talk about salivary glands, right? Certain glands in the urogenital system, we'll talk about all of that. So for example, we'll just take a gland structure, right? Just to make this picture clearer, right? So if I draw something like this, right? Right, this is a salivary gland, huh? Right? You all can draw nicely. Something like this. Draw. Right? Right? Let me make the duct a little bit long. Right? We are just taking one of these glands as an example. Huh? So these are these glandular epithelial cells. Right? These are the ones who are doing the secretion. Okay. Here we have the duct. Right. So these are the basic structure. Right. Okay. If you take the basic structure, guys, this is, you all know, this is from here to here. This is the duct of the gland. Duct. Right. From here to here, this is what we call the acinus, guys. Acinus of a gland. Right. Acinus. Okay. Duct and acinus. Right. These cells in the acinus, they are the secretory cells, right? Secretory cells, and you all know, guys, in these secretory cells, they have these secretory vesicles inside, right? From the secretory vesicles only, they are going to release whatever substance they produce. So, for example, in this case, if it is saliva, we have mucin, right? We have the various components of the saliva, right? The proteoglycan substances, all of these will be released from these vesicles, vesicles, right? Okay. Right. Okay. Right? Okay, just draw a rough one, huh? Nothing special here. Right? Look at this, guys. Now we will say there is a viral infection, right? A viral infection. So whatever, doesn't matter, right? We have talked about several types that are associated with Sjogren's. So let's say these viral particles, right? They have now reached this gland. They have reached this gland. Okay, viral particles have reached this gland, right? We know, guys, viral particles, they can directly enter these cells and cause direct damage, right? Direct damage to the cells, right? So you all can write that down. What is going to happen? There is going to be direct cellular damage from these viral particles, right? They are going to come into the cell. They are going to use up the cellular materials. They are going to propagate inside the cell. They're going to grow and replicate, right? So all of these are going to happen, and eventually the cell is going to die, the cell is going to burst, and it will do what, guys? It will release all its content to the outside, right? Once the cell undergoes damage, it's going to undergo apoptosis or necrosis, and then it is going to release all of its substance outside. Specifically, guys, on damage, right, on cell death rather, they are going to release, right, cytosolic and nuclear substances, right? All these cytosolic and nuclear substances will be released outside. So if we look at these substances, what are they, guys? What are they? Usually cytosolic, any structure from the cytoplasm, any structure. It can be ribosomes, right? It can be mitochondrial particles, right? Whatever damaged particles, lysosomal structures, right? Anything that was present in the cytoplasm can come out, right? Anything. Apart from that, during cell death, during destruction, any nuclear material also can be released. What are those, guys? Any RNAs, right? RNAs can be coming out, DNA particles, right? Anything from the nucleus, histone proteins, right? Histone proteins, right? Something like that, right? All of these can be coming out. All of these can be coming out, right? Cytosolic and nuclear material, right? Comes out. Okay. Now, look at this, guys. Now, from here onwards is where we are going to get the immune responses coming into play, right? Here on this side, we will look at the MHC2 problem, right? This is the major player, we said, MHC2 issues, right? MHC2 issues. So you all know, guys, MHC, major histocompatibility class 2, they are expressed mainly on this antigen presenting cells, right? APCs, right? Let's say I will draw it something like this, 2 lines here on these receptors to show MHC class 2, right? Later we will see MHC1, right? So this is an antigen presenting cell, right? It can be a macrophage, it can be a dendritic cell, whatever, doesn't matter, right? What is going to happen is, guys, now we said there are some HLA-DR mutations. So what is going to happen, guys? These MHC2 molecules, right? They are going to be a little bit abnormal now. What do I mean by abnormal? Right? Look at this. Let me draw something like this. These are going to be abnormal in shape, something like that. MHC2 molecules, right? Conformational changes. There are going to be structural changes in these molecules. Okay, nothing complex, no, right? Now, so these are due to the genetic problems, the HLA-DR problems, right? Now, what is happening, guys? Antigen presenting cells, you all know, how do they usually function? They engulf, right? They engulf certain substances, right? And they will express them. They will, first, let's draw the engulfing process. It will look something like this, right? Okay, they will engulf these, right? Put them into certain lysosomic structures, and they will break them down into small particles, and eventually they will express these on their MHC class 2 molecule. This is how MHC class 2 usually works, right? Now what is happening, guys? Because MHC class 2 function is abnormal, there is going to be what we call reduced immune tolerance. Reduced immune tolerance. What does that mean, guys? Now, these cytosolic substances, even if the MHCs have previously known that these are okay, these are our things, right? No need to destroy these. Now, what is it going to do? Because of the abnormal function, it's going to not recognize these structures, right? It is going to not recognize these structures. Therefore, it is going to evoke an immune response, right? So what is going to happen? MHC presents these to whom, guys? MHC presents these, MHC class 2 presents these to CD4 plus, CD4 plus, right? T lymphocytes, right? CD4 plus T lymphocytes, okay? CD4 plus T lymphocytes, right? Okay, there's an abnormal presentation of the cytosolic and nuclear material, right? Especially the cytosolic ones, nuclear ones, sometimes even in a normal case of MHC, they might not identify those. But if you all remember, we had some other genes to take care of the CT. See, we talked about the CTLA4, right? Specifically, we talked about how they take care of these nuclear substances, right? Either way, end of the day, what is happening, guys? CD4 plus T helper lymphocytes, right? They are going to get stimulated, right? They are going to get stimulated abnormally, even for the cytosolic self antigens, even for the self antigens, they are going to get stimulated, they are going to get activated. What do? Right? You all know the story here. Nothing much to talk about. We have talked about these several times, right? Th2 cells, Th1 cells, and Th17, right? These three mainly, right? But they are also there are other cell types as well, right? Not very necessary to talk about. These ones are going to get stimulated, right? Th2, you all know Th2, when they get stimulated, they go and stimulate, right? B cells, they cause B cell hyperactivity. And B cells, they mature into what? Plasma cells. They mature into plasma cells, right? Plasma cells. And plasma cells, you all know, guys, they start producing antibodies, right? Plasma cells start producing antibodies, right? Okay, these are auto antibodies. Antibodies against what, guys? Against these antigens that were presented before, okay? Antibodies against those, okay? Right? Okay. And then Th1 and 17, you all know, guys, just write this down now. We will see later what these cytokines do, right? They release a lot of other cytokines and chemokines, right? You all can write down cytokines and chemokines, right? Cytokines and chemokines will be released. Okay. Right. Look at this, guys. We'll continue there itself. These cytokines and chemokines released by these, especially these T helper type 1 and type 7T, right? Now you all know the antibodies released from the plasma cell. What do? They will go and form antigen antibody complexes and cause that antigen antibody mediated immune pathway, right? The cytokines and chemokines, guys, what they do, right? They further recruit, right, other immune cells, recruit other immune cells, right? Okay, this is what is giving rise to the inflammation, guys. This is another factor rather that gives rise to the inflammation, right? And because of this, guys, especially they are going to recruit a lot of lymphocytes. They are going to recruit a lot of lymphocytes, right? Lymphocytes, a lot of lymphocytes start coming to this area, right? To this glandular area, right? This is what we call lymphocyte infiltration, right? Lymphocyte infiltration. Okay. Give me a second, guys. Right. Sorry about that. This is where we see lymphocyte infiltration, mainly, guys, mainly CD4 plus. Write down mainly CD4 plus. Mainly, I will tell you all why that is important. We'll come to that later. Right? CD4 plus. Okay. And another thing, guys, due to these cytokines and these chemokines, right, specifically substances like TNF alpha and all of these, when they are released, we know there is also going to be some. Give me a second, guys. Really sorry about that, guys. I had a guest coming. Quickly send them away. Right? Okay. Can you all hear me? Right? Sorry about that. Right? Okay. So just write down fibroblast activation. Right? Fibroblast activation also can happen. Right? What is happening, guys? What just tell me, what do you all know? Whenever to a area where there's inflammation going on, inflammation or injury, when there is fibroblast coming into the picture, what is happening? What do you all know? Healing by what? When fibroblasts come.
Right. Scarring.
Healing with scarring, right? Healing with scarring, right? Just no need to write that now. I will tell you all when we come to that, but just keep that in your mind, right? This is the main thing. This is the main mechanism we see in our Sjogren syndrome, guys. The MHC class 2 pathway. right? MHC class 2 path, right? Now, what's the important thing we talked about, guys? Recently, what we have discovered this HLA B8 involvement as well. So we said there is an MHC class 1 pathway as well. It's not as much a major player. We don't see this even if you do the pathology, even if you do the biopsy, right? We will see only a little MHC1 mediated pathways within the biopsy. But nevertheless, they have shown to be, it has shown to be happening. So we'll talk a little bit about that as well, guys. What is happening with this MHC1, right? MHC1, MHC1, right? What do we see here? You all know where is MHC1 present, guys? Where is MHC now? MHC class 2, it's mainly in this antigen presenting cells. MHC1, where is it present?
In all cells.
Excellent. All nucleated cells. All nucleated cells have MHC class 1. So even these glandular epithelial cells, they also have MHC class 1, right? So we will just take a sample from here itself, from this glandular epithelial cell itself. We'll take a small sample, right? And we'll take a look at what is happening there, right? If we take a zoomed in view, guys, let's say this is, okay, sorry. Let's say this is my glandular epithelial cell, right? Glandular epithelial cell. And let's say this glandular epithelial cell, right? It has this MHC class 1, right? Something like this, one arrow there, okay? Okay, this is MHC class 1, MHC class 1 cells, receptors, right? MHC class 1. Now, what did we say, guys? There is going to be some HLA, especially this B8, right? Mutations with regards to this MHC class 1. So there is going to be abnormalities in the structures of MHC class 1 as well, right? So what is going to happen, guys? You all can, just to symbolize that, right? You all can draw something like this. These structures, you all can draw it a little bit abnormal. Due to the genetic mutation. Now tell me this, guys, MHC class 1, usually what is their function? What do they do, MHC class 1 molecules? What do they do? Huh? What do they do? Sorry?
And endogenous antigens, like it presents itself for.
Excellent, right? If something enters a cell, right, they will take that up, right? Whatever, doesn't matter if it's a viral particle, bacterial particle, doesn't matter, whatever, right? Whatever is inside the cell, they will take it up, right? And usually even the cytosolic substances and all of these things, they will present it there, right? And to whom are they presenting this? To whom are they presenting this?
CD8.
To CD8, to CD8. Look at this, guys. Now we know when the viral particles infect, guys, some of these viral particles will be inside this cell, right? Some of these viral particles will be inside this cell, and some of them will be taken up into these lysosomes where they are broken down, right? Now, normal function of the MHC class 1 would be to express these on the surface and therefore evoke an immune response, right? Now what is happening, guys? We know as the viral particle is there, some of the cellular structures also undergo damage. So we said some cytosolic substances, some nuclear proteins, these can all be present within this cell as well, right? Now what happens? Because the MHC class 1 is abnormal, because the MHC class 1 is abnormal, it will present some of these viral particles. But at the same time, what will it present? It will present some of our nuclear material, some of our cytosolic material. All of these will be presented by this MHC class 1, right? With the loss of immune tolerance, right? They will present them as harmful substances. Okay, they will present them to the immune system as harmful substances. True, we cannot say that viral particles will not be presented. We cannot say that because that also happens, although the MHC1 is abnormal. But the abnormal part is that the self antigens, for example, our cytosolic substances, our nuclear substances, these are also now being presented on this MHC class 1 molecules, right? To whom they are going to be presented to CD8, CD8 plus cells. Okay, CD8 plus cells. Okay, CD8, CD8 plus cells, right? CD8 plus cells. Okay, right? And what happens when CD8 plus gets activated, right? True, they will also produce some cytokines here, right? You all can draw this in the same color, right? These cytokines and some chemokines they will also produce. But what is the important thing? What is the important thing? What do CD8, how do CD8 T cells do its function, guys? What does it produce? What is the special substance?
Cytotoxic.
Cytotoxic substances. Yes, can you be a little bit more specific?
Granzymes.
Sorry?
Granzymes.
One is granzymes, excellent. Anything else? One?
Perforins.
Perforins, excellent. These two are the major ones, guys. You all can put it in a red color and a, right, something like that. And let's say another blue color substance, something like that. This is perforins, and the red one will say granzymes, right? Perforins and granzymes. What do the perforins do, guys? What do the perforins, just like the name says, what does it do? Perforins.
Perforates.
Yes, they perforate the cell because now inside the cell, right, your immune system has been given the signal that there are viral particles inside this cell, right? So what is going to happen? This fellow is going to come and it's going to make holes in this membrane, in this cell membrane. It's going to make holes like that, perforate. It's going to perforate, right? And once the holes have been made, granzymes, guys, then the granzymes come into play. They can enter the cell through these holes, right? Okay, like that, right? And they induce apoptosis, right? Perforins and granzymes, right? Perforins and granzymes. Okay, right? Now, okay, did everyone understand up to this point? All good, right? Today is not a very complex class, guys. Okay, we will see, right? Right, so perforins and granzymes. Now, apart from that, don't forget some other cytotoxins and cytokines and chemokines can also be produced, right? They will also help, right? Cytokines and chemokines, you all can put it like that. They also will help recruit these other cell types, right? Lymphocytic infiltration, fibroblast activation, all of these will play the role together. The cytokines and chemokines released from the CD8 plus T cells as well. Now, look at this, guys. What do I want you all to understand here, right? This MHC class 1 pathway, I want you all to make sure that you all may know that this is not the major pathway. This is not the major pathway. Why am I stressing this so much that MHC2 pathway is the main pathway? Because, guys, now y'all can put this as a side note, right? Sjogren syndrome, their clinical presentation, we'll talk about their clinical presentation. Firstly, there are some cardinal manifestations, which are mainly the glandular ones. And then there can be extraglandular manifestations all over the body, the autoimmune. No? In a similar way, in a very similar fashion, HIV/AIDS patients also can present, right? HIV/AIDS patients also can present with the viral infection in all over their body. So therefore, what is the importance when we do biopsy, guys? When we do biopsy, in a Sjogren's patient, right, we will see predominance of CD4 plus infiltration. This is very important. Whereas in an HIV patient, their major mechanism is what? In HIV, cytotoxicity. In HIV, the major mechanism is MHC1 related mechanisms, right? So there are the lymphocytic infiltrations. When you look at in pathology under lab, under the microscopes, basically, When you look at the lymphocytic infiltration, what do you see? CD8 plus predominant, right? So in Sjogren's, we see a CD4 plus predominant lymphocytic infiltration. Do not forget this. Do not forget this. Very important. Sometimes just clinically, it's almost impossible to discern the two, right? Just clinically, it's difficult, right? But what we can use is the biopsies. Okay? And in the biopsies, we see lymphocytic infiltration in both. In Sjogren's, is CD4 plus predominant. In HIV, CD8 plus predominant, right? This is why I want to highlight this, but both will have. So for example, an HIV patient also has CD4 plus infiltration, but it is not the predominant one. The predominant is CD8 in HIV. In Sjogren's, they also can have CD8 plus cells coming in. That's what we have talked about now because of the MHC1 mechanism, right? But predominance is CD4 plus. Okay, that word predominant is important. Okay, that's how you differentiate the two. Right. Then, so that's one point I want you all to know. I hope you all wrote that down. Huh? Right. The next thing, guys. So what is happening? We saw from this B cell hyperactivity, we have auto antibody production. Okay. Auto antibody production is there, right? Lymphocytic infiltration is there. Right? So look at this, guys. These two together, what are they going to do? The lymphocytic infiltration and the auto antibody production. They are going to cause destruction of secretory cells, right? Especially in these exocrine glands. Then what is the next one we have, guys? Fibroblast activation. What is this going to do? Healing with fibrosis, right? Healing with fibrosis. Now, destruction of secretory cells and healing with fibrosis. What do you all think? Sjogren's syndrome, can we completely cure this in a patient? Can we completely cure it? No, right? There is no curative drug, right, for the Sjogren syndrome. Why? There is destruction of the secretory. First of all, it's an autoimmune condition, right? There is destruction of the secretory cells, and whatever is healed usually heals with fibrosis, right? Okay, so this is a slowly progressive disease, right? Okay. So treatment, we will see when we come to the treatment part, it is only symptomatic, right? We will talk about the treatment later, right? Did everyone understand this pathophysiology? This is the pathophysiology. Always remember, right? MHC class 2 mediated pathway is the main one, okay? Okay. What are the main features? Antigen antibody, basically autoantibody production and lymphocytic infiltration. Do not forget those two. And then we have fibroblast activation as well, right? The main two, autoantibodies, lymphocytic infiltrations. And that also CD4 plus mainly, predominant. Right. Then these autoantibodies, guys, just to talk a little bit more, we will talk more in the diagnostic part. Just know autoantibodies, there can be many, guys. We are going to talk about several autoantibodies that are seen in Sjogren's patient. The most specific ones for Sjogren's is what we have talked about before as well in our SLE class, right? First one is anti-Rho, right? This is SSA, or we have anti-La, right? This is SSB. What is this SS, guys? What is the SS story? Sjogren's syndrome, right? Sjogren's syndrome, A-type antibody. Sjogren's syndrome, B-type antibody, right? These are just proteins. We'll take a little bit more of a deeper look than we talked about that day, guys. This Rho and La, right? These are proteins that are present in our cells, in our nucleated cells, right? Look at this. Rho, right? Rho proteins, guys, we mainly have two, right? Rho 52 and Rho 60. Rho 52 and Rho 60, right? Rho 52 and Rho 60. All right, now we are not going to go into the super depth of how these function, but what, just a sentence about these. Row 52, guys, this is a ligase protein. It's a ligase regulatory, ligase plus regulatory function, regulatory protein, right? It's a ligase type protein. Put a plus sign and say it's a regulatory protein as well. Why do we say it's a regulatory protein, guys? Right? It is we say it is a negative regulator of inflammation, right? This row 52 protein, what it does, guys, it has an effect. It can control inflammation, local areas inflammation. How does it do that, guys? It has an inhibitory action on certain cytokines, right? On certain interleukins, right? And in certain interferons as well, right? So this is how this row 52 protein acts, right? It is a ligase protein. It's a regulatory protein. It can go and ligate some of these bonds formed during inflammation, right? And it can deactivate some of these cytokines, interleukins, and interferons. Now, if there is an antibody against the row 52, what will happen? What is the end result? If there is anti-row or SSA antibodies, what is going to happen? What is going to happen?
Enhances the inflammation.
Yes, it is going to uncontrolled, more than enhanced, we would say uncontrolled inflammation, because this guy is responsible for regulating inflammation. So now it is going, when there is an antibody against it, inflammation is going to be irregular. It is going to be uncontrolled inflammation, right? Similarly, guys, row 60. Another thing, this row 52, you all can just note it down. This is a cytosolic protein, guys. It is in the cytoplasm. This is a cytosolic protein. Whereas row 60, guys, this is a nuclear protein. It is a nuclear protein, right? It is a nuclear protein. Row 60, guys, it is an RNA binding protein. RNA binding protein. Okay, RNA binding protein, right? What does this mean? What does it do? Right? There are many different types of RNA binding proteins, guys. This specific row 60, what it does, right? You all can write it down. It binds, right, to abnormal RNAs, right, and corrects misfoldings, Now you all know, guys, during replication processes, right, translation, transcription, in these processes, there can always be mistakes, right? There can always be mistakes. But why is my face like this today? Why was it the same probably as last week when you all saw me? Why is there no structural deformity yet in my face? Because even with these mistakes happening, right? Take skin cells, for example. Even with these epithelial cell during replication, whatever mistakes happen, our body has ways of correcting them, right? This row 60 is one such protein, right? It corrects any misfoldings, right, of RNA. Okay, right? So antibody, anti-row, guys, it can be either these anti-row 52s or anti-row 60s. Can be either of the two, right? Okay. Then anti-La. What is this anti-La? Again, it is another nuclear one, guys. It is another nuclear one. Right here, we are talking only about one thing. This is also a RNA binding protein. This has a different function, though. It binds to RNAs, but it has a different function. What it does, right? Once anti-La comes and binds, guys, right? What it does is it has a protective function, right? Protects newly formed RNAs. How it does is that, guys, is a very deep process, but just remember, right? Structural stability, right? You all know these nitrogenous bases and all are there in the RNA structure, right? So what these La proteins do, not the anti-La is the antibody. What the La proteins do, they can come and bind to these newly formed RNA molecules and they stabilize their structure, right? So there's a protective function. right? So these are these anti-rho and anti-la. So as you can see now, what can you tell me based on the information that we have just learned in Sjogren's? In Sjogren's, what I want you all to understand, get the broader picture, right? We saw initially there was an environmental trigger that can come in, especially these viral infections, but it was already in a genetically susceptible individual. That's what we said, right? Now look at this. Once Sjogren starts, what is it going to do? It has this anti-rho, anti-la antibodies being produced. Those can further do what? Further cause genetic abnormalities on a genetic level, guys. Molecular abnormalities on a genetic level, right? So these can exacerbate. That's why that's why these autoimmune conditions, guys. That's why we say they are related to one another. Usually, Sjogren's patients they come with lupus. Usually, lupus patients come with Sjogren's, right? Okay. Only one disease alone in these autoimmune conditions is not very common. Not very common. Okay. Okay. Understood. Right. Apart from this, guys, there are some other autoantibodies. I just wanted to talk about this one now. We'll talk about the other ones. There's rheumatoid factor that can be positive. There's ANAs, right? We'll talk about all of those. Right. Just know what these Rho and Las are for now. Right. So that's about it, guys. That's about it for the pathophysiology. Okay. Now we will come to the clinical picture. What do we see in these patients? Right. Clinical picture. Right. What do we see here? Right? Clinical manifestations of Sjogren's. Sjogren's, guys, first of all, there are some general manifestations. General manifestations, these are highly unspecific, right? Fatigability, right? Fatigability, you can say, right? Low-grade fever, all due to the systemic inflammation that is going on. And then especially once the joints get involved, right, we can have myalgias, arthralgias, all of these can be there. Okay, arthralgias can be there, right? Then guys, then look at this. Then we'll come to the most specific ones, right? We said Sjogren's mainly affects exocrine glands. Two of the major ones affected, guys, are the eyes, right? The lacrimal glands and the mouth, salivary glands, right? So let's take a small look at this, right? You all can start at the middle of the page. You all can draw an eye. Okay. Right. An eye, right? In this eye, guys, you all know lacrimal gland is located somewhere here, right? Looks something like that. Lacrimal gland, right? And here, guys, you all know we have this structure that drains. So lacrimal gland will secrete the tear, right? And this structure, it drains all these tears, right, into this. Let me draw something, right? Into this structure. We will name this, for now, just draw it. And it eventually connects to where? Connects to our nose. This is why, guys, this connects to our nose, like this is our nose, right? Okay, it looks like a cat's paw. It's a nose, I drew a nose. Okay, right? Right, this is why sometimes you all must have noticed when you all are crying, tears are coming at the same time. What is coming? Snot is also coming out. Okay, this is the reason, because these systems are they're interconnected with each other, right? Okay, draw this. We will name these parts just to learn some anatomy here, right? So that we can correlate it with the pathophysiology that's going on, right? So this one is the lacrimal gland here, lacrimal gland, right? Lacrimal gland. So the lacrimal gland, guys, it will secrete the tear, right? It will secrete the tear, right? I will draw it in a blue color or something. Yeah. And this tear will travel all over the eyes, guys, and it will reach this corner, right? The epicanthal area, we call this the epicanthal area, right? Now, once it comes here, guys, you all can see, right? There is these two small holes here. Let me draw it like that, right? These are two small openings, two small openings there, right? Two small openings. These two openings, what are they called? What are they called? You all can see these, not on yourself, it will be a little difficult. You all can look in someone else, right? Your friends or what are these two holes here, guys? Noah? What are these called? No? These are called the puncta, guys. Puncta, singular is punctum, okay? Plural is puncta, okay? There is one superior, one inferior, right? Puncta, right? These puncta, what do? They help drain this, drain the tear. They help drain the tear. They will drain the tear into what, guys? Into this tube, which we call the lacrimal duct, right? The lacrimal duct. The two lacrimal ducts, guys, the two lacrimal ducts get together, right? When they get together, guys, there is a small valve here. There is a small valve. When the two lacrimal ducts come and join together, there is a small valve in that area. That valve, we give a special name. What is the name for that valve? Very special one. Valve of Rosenmuller. Valve of Rosenmuller. Okay, valve of Rosenmuller. Right, this is some ophthalmology for y'all. I know some students are having ophthalmology this semester. You all have to know this. Right? Right? And then this tube-like structure, guys, right? This one is what we call the lacrimal canaliculus. Lacrimal canaliculus, right? Lacrimal canaliculus. Okay. And this large structure here, right? This is the lacrimal sac. Lacrimal sac. Okay, lacrimal sac. Right? So the tear comes all this way, guys, right? The tear comes all this way. Okay. Okay, and finally can come out from here, right? This is what we call the nasolacrimal duct, guys. Nasolacrimal duct, right? Nasolacrimal duct. Okay. Here, guys, where the nasolacrimal duct ends, right? There is another valve. There is another valve here. There's another valve here. What is this valve? This is called the valve of Haisner, right? Valve of Haisner. Okay. Right. This is just anatomy. Just anatomy for you all to get an understanding, right? Why this is important, we will see. Even in the treatment part, this is a little bit important, right? Okay, so this is the basic structure and how the tear flows, right? Now, what I want you all to understand is this, guys. In the case of Sjogren's, right? In the case of Sjogren's, what do we have, guys? We can have T cell infiltration coming into this area, T cells infiltrating here into the gland, right? At the same time, what do we have, guys? B cell hyperactivity, or plasma cells rather, right? Which are producing antibodies, right? Against these lacrimal gland cells, against the lacrimal gland cell. So what are we going to have, guys? we are going to have autoimmune destruction of the lacrimal glands, right? Autoimmune destruction of the lacrimal glands. This is going to give us what? A dry eye. Dry eye. Okay? Dry eye. Right? Dry eye. Okay? This is called, guys, this dry eye. It is the special name. The special name we can, one is xerophthalmia. Xerophthalmia, right? Xerophthalmia. This is one name. Same thing, right? Same thing. Then commonly, guys, when this eye is dry, right? When the surface of your eye, when it is dry, right? What is happening? There is going to be increased friction, right? There is a chance of infections and all of these. So there can be inflammation. There can be inflammation, right? Inflammation can be there. When there is inflammation here, guys, when there is inflammation here, especially if it is the cornea, if it is the cornea, what do we say? Inflammation of the cornea. How do we call it? What is the special word? Inflammation of the cornea. Sorry? Keratitis, right? Keratitis. There can also be, guys, inflammation of the conjunctiva, right? Conjunctiva. What do we call that? Conjunctivitis. Okay, conjunctivitis. Now, in these patients who have Sjogren's, guys, we commonly see this, right? We see the dry eye and the resulting inflammation of the cornea and conjunctiva, right? Therefore, what is the another name? So one name is xerophthalmia. Zero means what, guys? Xerophthalmia. What is the zero part? It means dry. Okay, xerophthalmia, right? That is one word. Another word commonly used for this dry eye is, guys, keratoconjunctivitis sicca. Keratoconjunctivitis sicca. Why kerato? Cornea involvement. Why conjunctiva? Conjunctival involvement. Both inflammation, itis, right? Keratoconjunctivitis. What is sicca? Sicca means dry, right? Okay. So this xerophthalmia and keratoconjunctivitis sicca both mean the dry eye. Both mean the dry eye. The word keratoconjunctivitis sicca, it is a little bit more specific. It also talks about the inflammation that is going to happen here, right? Inflammation that is happening here, right? Now, we'll learn a little bit more about this dry eye, guys, right? To get a good understanding of this dry eye, right? You all can put it as a separate note. When we talk about dry eye, guys, when we talk about dry eye, yeah. When we talk about dry eye, guys, there is mainly two types. There are mainly two types. What are these two types? One is called hyposecretive dry eye, right? The other one is called evaporative dry eye, right? These are the two types of dry eye. Now, just from the name, which one, just from the pathogenesis and the pathophysiology we have talked about, which one do you think happens in Sjogren's? Hyposecretive or evaporative?
Hyposecretive.
Hyposecretive. Why? There is a problem with the gland secretion. Now, when the gland is having autoimmune damage, the secretory function goes down. Now, to understand this hyposecretive and evaporative a little bit more, guys, we will look at this physiology here. We will look at the tear film. There is something called the tear film, guys, in your eye, in the globe of your eye. There is always a layer of fluid. There is always a layer of fluid. Now, that can be sometimes increased. For example, when you all yawn, sometimes more tears can be secreted. That variability is there, but always there is a constant flow, right, of this fluid within the globe of your eye. This is what we call the tear film, right? You can put this as a note, guys. This tear film, we'll look at this tear film a little bit. The tear film, guys, if you look at the eye, it looks something like this, right? If I draw the eye like this, the tear film, it is made up of 3 layers, guys. It is made up of 3 layers. Inner layer, right? One. Then in another color, you all can draw the middle layer. Okay. Yeah. 2. Okay. There is no gap between the layers. Huh? Just draw one on top of the other. 2, and then the outermost layer. 3. Huh? So you all can use 3 colors. Huh? So the tear film comprises of 3 layers, guys. The tear film. Okay, tear film. This is the tear film. Right? Tear film. What are these 3 layers? What are these 3 layers? Right? We have first one, the innermost, guys. Inner, we say mucin layer. Inner mucin layer. Right? Then we have the middle aqueous layer. Aqueous layer. Inner mucin, middle aqueous, and third one is the outermost outer lipid layer. Outer lipid layer. Outer lipid layer. Right? Inner mucin, middle aqueous, and outer lipid. Now look at this, guys. The inner mucin layer, this is the thinnest layer. You all can, if you all want the measurement, this is about not necessary, 0.1 micrometers. The middle aqueous layer, this is the thickest layer, guys. This is the thickest layer. This one is about 8 micrometers, right? 8. And the outer lipid layer is somewhere in between, about 0.5 micrometers. Okay, about 0.5, right? Now, here's what I want you all to know. Inner mucin layer is produced by whom? Who produces the inner mucin layer? Mainly, guys, conjunctival, write this down, conjunctival goblet cells plus the conjunctival goblet cells and the lacrimal gland. Lacrimal gland, right? They produce together the inner mucin layer. The middle aqueous layer is only produced by the lacrimal gland, guys. Lacrimal gland, right? And the outer lipid layer, guys, this is produced by a special structure. You all will learn this, guys, right? Something called the meibomian gland, right? Meibomian gland. This produces this outer lipid layer. Outer lipid layer, right? Right? Now by understanding this, tell me this, guys. If I say someone is having an evaporative type of dry eye, listen carefully. Someone is having, a patient is having an evaporative type of dry eye, right? Which of these 3 layers do you think is mostly affected? The outermost layer or the inner layers? Which one? For an evaporative one.
Outermost.
The outermost, the outer lipid layer. The outer lipid layer. Why, guys? When this outer lipid layers function, it actually has many functions, including reduction of surface tension and all of that. But another very important function of this outer lipid layer, right, is to prevent evaporation. It's to prevent evaporation of the other 2 layers, the inner mucin and the middle aqueous layers, right? But if there is some defect in the outer lipid layer, what is going to happen? The middle aqueous and the inner mucin layers are going to start evaporating because they are going to be exposed to the environment, right? So this is what happens in certain meibomian gland related diseases, guys, right? You always study these in ophthalmology, right? So in those diseases, there is a evaporative form of dry eye. Now, forget that. As opposed to that, what is happening in Sjogren's? In Sjogren's, we have the lacrimal gland itself being destroyed. What is defective? What is defective? The middle aqueous layer and the inner mucin layers, right? These 2 are going to be defective. So this is a hyposecretive form of dry eye, guys. The outer lipid layer can still be fine, but doesn't matter. The entire tear quantity, right, is going to be reduced, right? Because this aqueous layer is the largest layer, and the mucin layer is also very important. What is mucin, guys? What is mucin? It is a what is mucin? We have talked about mucin in some other structures. In the GI system, we have mucin, similar structure. It is a glycosylated protein. Huh? It is they are very high molecular weight. These mucins, they reduce friction. They give a nice smooth surface. They give a nice smooth surface. Huh? Right? So just know, right? This is just some extra knowledge for you all. The dry eye is a hyposecretive form when it comes to keratoconjunctivitis sicca, or when it comes to Sjogren's, right? Xerophthalmia, basically. Right? Now, then, so that is about the physiology part. How does the patient complain to you about this dry eye? How will a patient complain to you? What will they tell you? What will they tell you?
Itchy eyes.
Itchy eyes. Yes. Okay, good. Anything else? How they say is, guys, okay, if you all haven't experienced this, you all must be having these standing fans at home, right? Go in front of the fan, put it on power 3 or 4 or the highest one, right? And right, do the Mr. Bean thing, right? Go and stay like this in front of the fan. You all will feel what these
Burning
dry eye
sensation.
patients. Yes. Sorry.
Burning sensation, yeah.
Yes, there is going to be a burning. How they complain is like this, guys. Firstly, they will say, especially if it's a mild case, they will say, doctor, I feel like there is something always in my eye, right? I feel like there is something always in my eye. I have to blink often, doctor. Otherwise, my eyes burn a little. I have to blink a lot, right? I feel a sandy feeling. I feel like there is some sand or something stuck in my eye, right? A gritty sensation, right? These are what they complain, right? These are what they complain, guys. So you all can write these down, right? Sandy or gritty sensation. Gritty sensation. Then yes, burning sensation. Burning sensation, right? And blinking. Blinking, you all know, it's usually involuntary. Involuntary, right? Now what is happening when this is there, guys? The patient gets the urge to blink this and he knows it, right? So this blinking becomes a voluntary procedure now, right? He has to think about it because his eyes are burning a little bit. So he has to think about it and constantly blink, right? Okay. So y'all can write those down. Apart from that, guys, so when there is inflammation, this is what we talked about, the keratoconjunctivitis, there can be redness, right? Redness, right? Hyperemia, right? We call these injection sometimes, red injection. We all these for ophthalmology. These are ophthalmology terms, guys, right? Not necessary for us here. Apart from that, right? They can also have. Now, tell me this: how will they complain to you, doctor? It's worse during the day or worse during the night? Why?
Worse during the day.
Why worse during the day?
I'm assuming during night time most people keep their eyes closed while
All
sleeping.
right, eyes closed. Okay, eyes closed at night. What is happening when the eyes are closed? Why is it better?
Parasympathetic drives more.
Okay, don't think too much. Don't think too much. Just think the basic. What is happening, guys, when our eyes are open? When our eyes are open, the tear film is exposed to the environment, right? So there can be some evaporation going on. There can be some evaporation going on, right? But what is happening now when the patient is having Sjogren's, he already has a hyposecretive dry eye. On top of that, when his eye is open, what is happening? The outer lipid layer is also getting evaporated during daytime when his eyes are open, right? So during the daytime, right, he already has hyposecretive form of the dry eye, and on top of that, when the eyes are open, you are adding the evaporation as well, right? So the dry eye is more severe during the day, but during the night, the eyes are closed. True, the patient has a hyposecretive form of dry eye, but at least his outer lipid layer will not be evaporating as much because his eyes are closed, right? Okay. So that is why they will complain, guys, usually worse during the day. Worse during the day. About the parasympathetic effect, you all are correct, but don't think too much. Don't think too much. That is for your level definitely not needed, right? There is a parasympathetic effect with regards to the exocrine glands, right? Not necessary, right? Right. And guys, in severe cases, especially when the inflammation, especially when the keratoconjunctivitis becomes severe, there can be blurring of vision, blurred vision, right? This is in severe cases, Okay, right? So this is the dry eye. This is about the dry eye, right? Dry eye. The next one is, guys, dry mouth. Right now, when you are drawing it, guys, make sure you are drawing. So I'm trying to draw a triangle. At the end of the day, we are going to talk about this main triad, right? So on the top end is the dry eye, right? Here we will talk about dry mouth. What is happening here? Dry mouth. Again, what is this, guys? A problem with the exocrine glands. In this case, salivary glands. Salivary glands, right? Here, look at this, guys. You all can draw a person. Something like that. Yeah, just someone. When we look at salivary glands, guys, there are major salivary glands and some minor salivary glands, right? What are these? The major saliva, we'll draw just the major ones, right? Here, there is one large one, right? And somewhere here under the tongue, we will have one, and somewhere here in the mandibular region, we'll have another one, right? Just roughly, these are not accurate diagrams, just for you all to get an idea, right? These are the three major salivary glands, right? The three major salivary glands, right? We have the parotid gland, right? We have the sublingual, right? Sublingual gland, right? And the submandibular, right? These are the three main parotid glands, right? These are the major, major salivary glands, right? These are the major salivary glands. Apart from these, guys, there are some minor salivary glands. What are these, guys? We have some salivary glands on our lips. We call this the labial glands, right? Again, we have on the inner surfaces of our cheeks, right? We call this the buccal one, right? Then we have another one on the hard palate, right? Palatine salivary glands. And finally, on our tongue also, guys, we have some lingual salivary glands, right? Lingual salivary glands. Okay. Now, just know, guys, the function of all of these, minor and major, is affected in Sjogren's. Okay, minor and major is affected in Sjogren's, right? So we are going to get reduced secretion of saliva, therefore dry mouth, right? What is the special word here, guys? What is the special word? If I'm using just like xerophthalmia, another word.
Xerostomia.
Excellent, right? Xerostomia, right? Xerostomia, right? Xerostomia. Now, how will the patient come to us? Look at this, guys. How will the patient complain to you, right? One is, okay, if you all have, it's difficult to experience dry mouth unless you all are teaching someone, okay? So for me also, occasionally I come across this dry mouth scenario, right? Then I have to stop for a while and drink water, right? Here, guys, how the patient complains is one of the most common ones: inability to speak continuously for a long period of time. Even for short periods, guys. Sometimes they cannot speak more than 2 to 3 minutes at one go, right? If their dry mouth is severe, right? So inability to speak continuously, right? Inability to speak continuously. Then they will also complain, guys, difficulty in swallowing. What is the scientific term here? Huh? Yeah, dysphagia. Just note that, guys, especially with dry foods, difficulty swallowing, especially with dry foods. And they will usually complain, without a glass of water, doctor, I cannot eat anything, right? They have to always have a glass of water or cup of water with a meal, right? Okay. Then another one, guys, right? Another one, they can have, now this saliva, guys, under normal physiology of the saliva, right? We have talked about this in the gastrointestinal system as well. There is always a constant rate of saliva production, guys. Now this rate can vary depending on which phase of digestion we are in, right? For example, when you see a pizza, what is going to happen? Okay.
And your
Yeah,
voice is
just
getting
talking about, sorry. Shashank, I did not hear you. Sorry. Okay, I think I am stuck.
Your voice is breaking. Yeah.
Okay. Give me a second, guys. Guys, can you all hear me? No? Still no?
Yeah. I can hear you.
Okay. I think there is some network issue. I cannot see you all as well. Just let me know if it's not clear. Huh?
All right.
Right. Share screen. Right. Guys, can you all see the screen? I cannot see you all. Can you all see the screen? Yes? No?
Yeah.
Yeah, okay. Right? Right. So what is going to happen, guys? Under normal physiology, right? We usually have something called a salivary flow rate, guys. We have something called a salivary flow rate. So this saliva is, guys, can you all hear me? Yes?
Yep.
Okay, good. Right, so we have something called a normal salivary flow rate. Now this can fluctuate throughout the day, throughout various activities, meals, right? With chewing and all of these things, the salivary flow rate can vary, right? But we have a baseline salivary flow, which means always in our oral cavity, there is some saliva flowing, right? There is some saliva flowing, right? Now, what is the important thing I want you all to understand here, guys, right? In the case of dry mouth, right, this salivary flow rate, the flow of saliva, right, is going to reduce, right? Flow of saliva is going to reduce, right? When the flow of saliva reduces, guys, what is going to happen, right? You all know this flow of saliva is very important, right? To control microbiomes in your oral cavity, right? In our oral cavity, guys, you all know there are bacteria, right? There are bacteria, and how they are maintained is, right? You all know there is something called plaque formation, right? These things are prevented by this saliva flow. But when the flow of saliva reduces, what happens? The mucosal defense mechanisms in your oral cavity also reduce, right? Mucosal defense mechanisms also reduce. When that happens, guys, what is happening? These patients show increased dental caries, right? Dental caries, right? Dental caries. Okay. Right. Okay. Right. Then guys, when the dry mouth becomes a little bit more serious, when it becomes a little bit more severe, what is going to happen, guys? Right? They tend to show fissuring and cracks, fissuring and cracks on the surface of tongue, on the tongue. Okay, fissuring and cracks on the surface of the tongue, right? And when there are fissurings and cracks, guys, what is happening to the surrounding areas which don't have cracks? They undergo inflammation and they swell up a little, right? So this gives a hyperlobulated appearance. Lobulated appearance, right? A hyperlobulated appearance. Okay, hyperlobulated appearance, right? Okay. This is there in your skeletal note, guys. Just go to your skeletal note, right? I have put a picture. Look at this, right? Can you all see? Fissuring, guys, can you all see? Actually, can you all see? Huh? Can someone unmute?
Yep.
Yeah, okay, good. Right? So there is dental caries, as you can see, right? These are the dental caries, right? Multiple, right? Multiple, right? And then fissuring and cracks, right? In this tongue surface, you all can see here, guys, right? Fissurings and cracks, right? This one is a not very severe case, but here it's a little bit more, right? There is fissurings and cracks, and other areas look hyperlobulated, guys. This is what we call hyperlobulated, right? Hyperlobulated. Okay. Okay. We see a similar picture, not exactly similar, in certain conditions, in one condition, in the intestines. We can see fissuring and cracks, and the other areas a little bit swollen. Where do we see such a picture? Crohn's disease. I hope you all remember. Go and look at your notes. In the intestines, we can see such a picture, right? Similar thing happens here as well, right? Right. Then, where were we? Right, we are here. Right. And again, guys, in further severe cases, sometimes they can have altered taste sensations, right? Sensations, right? Especially due to this fissuring and cracks, right? They are going to destroy the taste buds, right? So there's going to be altered taste sensations. Okay, altered taste sensations. Right. So that's about the dry mouth, guys. The third most important one is an extraglandular manifestation, but they almost always present in Sjogren's, guys. So this dry eye and dry mouth are the main two, right? Apart from that, almost always we get this third manifestation. Where do we get this? This is, guys, in joints, right? We get an inflammatory type of arthritis, right? Inflammatory type of arthritis. Okay, right? So this is one of the extraglandular manifestations, and this is a major one, right? Especially in these joints, right? You can draw some joint like that. There is going to be inflammation. Now, this is an inflammatory type arthritis, guys. Inflammatory type arthritis, and specifically, we say sometimes when we do the serum analysis, we can find rheumatoid factor present, right? We can find rheumatoid factor present there for most of the time, right? This is going to be rheumatoid arthritis. Now, what are the features here, guys? Tell me. You all know inflammatory arthritis, right? What are the features? Now it should come. We are just finishing the
Morning stiffness lasting more than 30 minutes.
right. More morning stiffness lasting more than 30 minutes. Okay, good. Anything else?
Pain during rest.
Okay, pain exacerbated during rest. Okay, anything else? Anything else? What about If I tell you all are going to know the answer. Okay, let me just tell you, right? There is a symmetrical involvement most of the time, right? For these inflammatory type of conditions, there is symmetrical involvement, right? Symmetrical involvement, right? And in the case of Sjogren, you all can write this down. Huh? I hope you wrote those down. And in the case of Sjogren's, guys, just write down, right? It is usually a non-erosive type. You usually see arthritis, non-erosive types, right? Not very severe, right? There are no bone erosions, joint erosions, right? Non-erosive type, right? And on rare occasions, guys, you all can put it as rare, there is something called Jacob's arthropathy, right? This is a little bit rare, guys, right? We don't usually see this. Related with Sjogren's, it is severe deformities in the hands, right? Especially in the fingers, because their inflammatory arthritis is a little bit more severe, right? So you get this Jacob's deformity, right? We don't need to know about this. Just know that there is something like that, right? Jacob's arthropathy can be present, can be seen, right? Severe deformity, especially of the hands, right? Of the hands, right? These three together, this is the main triad of Sjogren syndrome, guys, right? Dry eye, dry mouth, and inflammatory arthritis, right? Dry eye, dry mouth, and inflammatory, especially rheumatoid arthritis, right? Most patients will present with these three together, okay? These three together, right? Then, guys, take your skeletal note, right? Okay. Right. There is a picture here. We'll talk about those. Come to this other organ involvements. Right? These are now the other extraglandular manifestations. These ones, guys, might be there, maybe not, right? Might be there, maybe not. It can be or cannot be there, right? Depends. But those first three, that triad, is almost always seen. Other organ involvements, not so common, right? It can happen, right? Maybe not, right? Okay, let's have a look. Pulmonary involvement, right? Again, guys, they can have, with regards to the exocrine glands in our respiratory system, right? They can have a dry cough, right? Zero trachea. What is zero trachea, guys? Again, the tracheal glands, right? The glands in your trachea, especially your mucus glands and these kind of secretory cell functions are going to be reduced. This is what we call zero trachea, so dry trachea, right? And rarely, guys, right, there can be frequent infections because of the consistent dryness, right? And there can be interstitial, there can be inflammation and then healing with fibrosis. This is what we call interstitial pulmonary fibrosis. When there is interstitial pulmonary fibrosis, what will our diagnostic test reveal? What sort of a lung? If you do a pulmonary, yes, when there is fibrosis, we have a restrictive lung pathology. Okay, restrictive lung pathology, right? Okay, then another one, guys, hematology, right? What can we see in the blood picture, right? Again, just like in SLE, all these things can be present, guys. Some exceptions are there. Look at this, anemia. Here, guys, mainly we again have anemia of chronic disease. What is anemia of chronic disease? How are you going to see this in the laboratory investigations? Guys, anemia of chronic disease?
Normocytic, normochromic.
Normocytic, normochromic. Here, guys, unlike in SLE, right, hemolytic type of anemia is very rare, right? For Sjogren's, right? We mainly have normocytic, normochromic, hemolytic not usually seen, right? Guys, is my video getting stuck?
Yeah, it's a bit laggy,
Yes.
but not the screen.
Not the screen. Okay, good. I have no idea. I cannot see any of y'all. It's not sure. I will see after the break, right? Right. Then again, leukopenia, thrombocytopenia, right? Hypocomplementemia. These all can be there, guys. These are generally in autoimmune conditions. We have all of these things happening. Non-Hodgkin lymphoma, right? This one is a little bit of a different story. This one has a close association with Sjogren's, guys. What they say is, what is this non-Hodgkin lymphoma, guys? It is basically a cancer of lymphocytes. Cancer of lymphocytes originating in lymphoid tissues, right? It originates in lymphoid tissues. Now, this we will talk about in depth in our hematology chapter, guys. Okay, but just for you all to understand, we say a patient of Sjogren's is having an increased risk of non-Hodgkin lymphoma if the following criteria are met, right? Write this down. Persistent parotid enlargement, right? Now, this is one thing I forgot to mention in our previous triad. We'll go back to that after this point. I will come back to that, right? Look at this, persistent parotid enlargement. Another one, right? Persistent or overt lacrimal gland enlargement, right? Lacrimal gland enlargement. And guys, just know there is something called cryoglobulinemia. We will talk about these in depth in the hematology chapter, right? These are big topics, right? And then persistent purpura, right? Okay, persistent purpura, right? Persistent purpura. If these are there, guys, right? Persistent parotid enlargement, persistent lacrimal gland enlargement, and cryoglobulinemia and purpura, right? Persistently. If these are there, we suspect non-Hodgkin lymphoma might be there in this Sjogren's patient, and therefore we have to do further testing, right? Okay, come back to this triad a little bit, guys. Here, one thing I forgot to mention. Look at this. Under this dry mouth, right? What have we said? There is going to be some sort of inflammation. There can always be inflammation, right? When there is inflammation, guys, sometimes if the inflammation is severe, right, there can be enlargement of these glands. Now, the most clinically evident one is this parotid, guys. Parotid gland enlargement can be there in the case of severe disease, right? This one, guys, now it is not usually persistent in the case of Sjogren's. Whenever Sjogren's, you all know it's an autoimmune condition, right? So depending on the, it's a progressive condition, and depending on some of the environmental factors, let's say a patient suddenly gets a severe viral infection, sometimes the manifestations can elevate a little, right? So depending on that, we see these parotid gland enlargement. So it can be recurrent in nature. It's not persistent in nature, it's recurrent. It can come and it can go, right? At the same time, guys, just remember in Sjogren's, right, it is usually bilateral in nature, right? This parotid enlargement is usually bilateral. Why? This is an autoimmune disease. It's an autoimmune disease. So both parotid glands are going to get affected, right? If it is not bilateral, guys, we have to consider other conditions, right? Okay, it can be a carcinomatic condition, it can be a benign tumor or whatever, right? But in Sjogren's, it's usually bilateral and recurrent in nature. If it is persistent in nature, suspect lymphomas. Okay, right, then we'll come back. Right, we are here. Apart from that, guys, right, what else? Vascular manifestations, again, like SLE, guys, right? We talked about the vasospasms, right? There can be Raynaud's can be there, right? Urogenital, specifically, guys, specifically in females, right? In females, there can be dryness, especially of the vaginal canal, right? There can be vaginal dryness. because of that, right, there can be discomfort during sexual activity. This is what we call as dyspareunia. This is what they will complain to you. This is how the patient will complain to you, right? Dyspareunia, right? Then apart from that, cardiology manifestations, guys, pericarditis, right? Renal, look at this. Now, what are we saying here? The autoimmune attack can be systemic. It can go to various organs and cause damage, right? Like that, when it goes to the renal system and causes damage there, it can cause diabetes insipidus, right? Now tell me this, what type of diabetes insipidus do we get with Sjogren's?
Nephrogenic.
Excellent. Why is it not cranial?
Because there's no problem with the secretion of ADH.
Excellent, excellent answer, right? There is no problem with the secretion of ADH, right? We talked about this in endocrinology, right? Diabetes insipidus, it was a big topic. We talked about two types, cranial diabetes insipidus, nephrogenic diabetes insipidus. Cranial is a problem with the secretion of ADH. Nephrogenic is ADH is fine. ADH is coming to the kidney, but the kidney is damaged. Therefore, the ADH cannot act, right? That is nephrogenic diabetes insipidus. So in this Sjogren's, we get a nephrogenic diabetes insipidus, right? At the same time, guys, we can get a renal tubular acidosis, right? Specifically, type 1 is more related with Sjogren's, right? You all know what is happening in type 1. Where does type 1 renal tubular acidosis happen, guys? Mainly, where does it occur? Which part of the nephron? Where does it occur? Renal tubular acidosis. In the proximal parts or in the distal parts of the nephron?
PCT.
Sorry?
Proximal.
Type 1? Type 1 mainly in the distal parts. Have you all heard alpha intercalated cells? Alpha intercalated cells, right? You all have done this, Go back to your notes and just check. In alpha intercalated cells, guys, here there is a problem, right? Especially in the distal nephrons, right? There is a problem with hydrogen excretion, H plus excretion, right? So H plus is not put into the urine. So what is happening? H plus stays and stays and stays and builds up, right? It is not lost with urine. So what is happening? Urine pH increases, guys. The urine pH becomes more alkaline, while our body, in our serum, the pH reduces. That is what we call a metabolic acidosis, right? Acidosis, right? There is no carbon dioxide problem there. So it's a metabolic, not respiratory. It's a metabolic acidosis, right? No need to know the exact, for students who have not come for those modules, it's okay, right? Other students just go and review what is RTA type 1, RTA type 2. You all have talked about even type 4. I think you all were given a small introduction to, right, in your chapters, right? So Sjogren's is mainly associated with this RTA type 1 because there can be autoimmune damage specifically to those pumps, to those ion channels, right, which are involved in hydrogen excretion, right? This RTA type 1 is also related with some sort of electrolyte imbalance. What is it related with? Anyone? No?
Hypertension.
Hypokalemia. Go back and check. Right? It is also related with hypokalemia. Right? Just go and check renal tubular acidosis. Right? Right. Nervous system, guys, not very common, right? CNS, depression, seizures, PNS, polyneuropathy is basically abnormal sensations, pins and needles sensation, tingling sensations, these kinds of things, right? For the peripheral nervous system. Gastrointestinal tract, again, not very common, guys, right? Especially maybe in severe disease, yes, otherwise usually not seen. Esophageal mucosal atrophy, right? And atrophic gastritis. These are basically due to the inflammatory damage with fibrosis, right? Healing by fibrosis, right? This is what happens. Okay, is that clear? Right? Right. Then guys, we will take a 10-minute break. We'll take a short 10-minute break and come back and do the investigations and the management, and then we'll be done. Okay, we'll take a 10-minute break and come back, right? Right. Is everyone back? Guys, can you all see me now? Am I good?
Yep, can see you.
Okay. So my internet package had run out. So yeah, Sri Lanka Telecom decided to give me a hard time, right? Until I paid more, right? Okay. Right. So where are we? We are at, we just finished the clinical manifestations. Now we have to talk about the investigations. Right. Look at this, guys. Share the screen. Right. Okay. Look at this, guys. I will, y'all can just note it down there itself if y'all want, right? I will go to a new page, right? Investigations, right? Okay, let me do it there itself. You all can write it down there itself, right? Firstly, guys, there is something called cyelometry. What is this cyelometry story, right? Cyelometry. Okay, cyelometry. Cyelometry, guys, basically this is a measurement of the salivary flow rate, right? This is a measurement of the salivary flow rate. There are two types, guys. There are two types of cyelometry. One is called unstimulated cyelometry. The next one is called stimulated cyelometry, right? So this for Sjogren's, we use this unstimulated cyelometry test, right? What's the difference here? Cyelometry, so we are measuring the salivary flow rate. Stimulated, what is this stimulated, guys? We basically, what we do is we can place some suction cup. There are different methods. We can place a suction cup on the parotid glands or wherever the gland, the ductal orifice opens into the oral cavity, and we give some stimuli to the patient. What sort of stimuli, right? Some sort of sour liquid, right? We are going to place it on their tongue, and that is going to stimulate the salivary flow. We are not talking about that. For Sjogren's, we are going to go with this unstimulated salivary cyelometry, right? Unstimulated cyelometry. Here, guys, what do we tell the patient to do? Nothing complex, huh? We tell them to sit quietly. You can write this down. Sit quietly. No talking or chewing, right? No talking or chewing. And what we tell them is whatever saliva that comes into their mouth, right? Spit it out into a small tube, right? For about 15 minutes, for 5 to 15. Usually we take it for 15 minutes, right? Whatever saliva that comes into the mouth, spit it out. No talking, no chewing, nothing. Okay. This tube is a pre-weighted tube, guys. Okay, it is a pre-weighted tube. Here you all can see, right? This is what they use. This is what they use. We just tell them to spit whatever comes into their mouth into that tube, right? And at the end of the 15 minutes, right, we check for the volume. Usually, guys, if the patient is having dry mouth, right, if the patient is having dry mouth, if the salivary gland, if the salivary flow rate is less than 1.5 ml per 15 minutes, we say this patient has dry mouth. Okay, dry mouth, right? So this is one of the diagnostic methods we can use for cyanometry, for dry mouth, right? Cyanometry. This is the first one. Now, what is the problem here, right? Any drug-related things that come to your mind that maybe you should pay attention to if you are doing this test? Nothing. Sorry?
Diuretics or anything?
Sorry? I didn't get
No,
you.
by now.
Okay. Do you all know any drugs that can cause dry mouth by themselves?
I was thinking
Right.
that, but I mean,
Yes. What drugs? What drugs? What kind of drugs?
Anticholinergic.
Excellent. Anticholinergics, guys. If the patient is already on an anticholinergic, right, or any other drug that has an anticholinergic side effect, right, anticholinergic drugs themselves or other drugs that have anticholinergic side effects, then we cannot do this unstimulated cyanometry or stimulated cyanometry for that matter, right? We cannot do cyanometry, right? Okay, then in that case, we have to go for other methods, right? Other methods, right? Okay, so cyanometry is one of the things, right? Just note that down. Cannot be done if the patient is on anticholinergic, right? Then, so that is about the mouth, guys. That is for the mouth. That is for the mouth, for the dry mouth, basically. Then we come to the eyes, guys. For the eyes, we have several tests, right? For the eyes, we have several tests, and actually the tests that are there for the eyes, they are better than the cyanometry for the dry mouth, right? We will see. There are several, guys. Write this down. One of the ones is TBUT, or some books say TFBUT, right? TBUT or TFBUT. What is this, guys? Tear film breakup time. Tear film breakup time. Test, right? Test, right? What do we do here, guys? What do we do here? Write this down. First, we'll write the procedure, and then I will tell you all what we do here, right? We use, guys, fluorescein eye drops, right? Fluorescein eye drops, right? We apply, we put some eye drops onto the eye, and we observe, right? Observe under what we call this cobalt blue, right? Cobalt blue slit lamp, right? Slit lamp, right? And what are we looking for here, guys? We are looking for, just write it down, I will explain. We are looking for, observe for time taken, right? Time taken, right? For appearance of dry areas, right? These dry areas, guys, we see them as dark spots, right? I will teach you, right? Don't worry, just write it down, right? Look at this, guys. Let me schematically show you what is happening, right? If we take an eye, right? This is an eye. Okay, this is an eye. What are we going to do, guys? We are going to add this fluorescein eye drops, and we are going to look at it under this cobalt blue, right? Cobalt blue. So you will see something like this, guys. It's going to appear in this bluish green appearance, right? I will just color it blue. The entire eye looks like this, right? This is what it looks like, right? Now what is going to happen, guys? So this is initially, right? Let me draw it like that. Let me draw it in 3 stages, right? What is going to happen? So you're going to continuously observe it under the slit lamp. Eventually, guys, what is going to happen? This fluorescein eye drop that you put, right? It's going to start drying up. It's going to start drying up. We don't allow the patient to blink during this time. The eye has to be completely kept open throughout this test. We don't allow the patient to blink. So therefore, this cobalt blue, this fluorescein dye that you applied is going to start drying up. When it dries up, guys, it's going to start appearing as patches, as dark patches, right? And eventually the entire thing will be dark once all the fluorescein eye drop is gone. Once the entire thing is evaporated or dried out, right? It is going to be appearing dark, right? This is the usual progression, Now, in a normal individual, when you do this test, what is happening, guys? We take the time from the start of the experiment, from the point where we put the eye drop, right? From there, right, up to the appearance of the first dark dry spot, right? Appearance of the first dark dry spot, right? That is the time we collect. We don't wait until the entire eye becomes dark, right, and dry. Until the appearance of the first dark dry spot, right? This is the time we take. In a normal patient, guys, this ranges from 10 to 35 seconds, anywhere from 10 to 35 seconds, right? It can take 10 or more seconds, basically, for this, for the first dry spot to come about, right? But what happens in the case of Sjogren's, guys? They already have a hyposecretion, right? Right? So their aqueous layer, their inner mucin layer, these are very thin. So evaporation occurs very rapidly when they leave their eye open for a long time, because throughout this test, no blinking. So what is happening in a Sjogren's patient, guys? If you look, right, Sjogren's patient, Sjogren syndrome, this will be less than 10 seconds, right? So the tear film breakup time is less than 10, right? That basically the time of the first spot to appear is under 10 seconds, and that indicates dryness, right? Basically dry eye, okay? This is one test, right? I think I have put some pictures here for you guys. Look at this. Okay, so this is it's a bluish green color. Depending on the color of the fluorescein dye, it can change a little, right? This one is a little bit more green in this picture. So basically, this is how these dry spots appear, guys. You can see, they become dark, right? Okay, and so as they become darker and darker, what is happening, guys? The tear film is getting dried up. What is happening? At one point, eventually, the patient will blink, right? He will be forced to blink. He will say it's very uncomfortable, right? Okay. Right. So usually we do this for both eyes, right? To test. Okay. So that's one test, guys. The second one we do is the Schirmer's test, right? Schirmer test. What is the Schirmer's test? This one, guys, this is actually, you all can write, this is the currently preferred one, right? Most labs, most hospitals, this is the one we currently practice. And even when you all go to the clinic, most of the time you all will use this one, Schirmer's test, right? What we do here, guys, this one, look at this. we take the patient's eye. I mean, we don't take it, right? We leave it there, right? But what we do, right, is we put a filter paper here. This is not, this is kind of a special filter paper, right? We put this filter paper like this, right? This filter paper, guys, it is marked. It has these readings of the millimeters, number of millimeters. This one usually is about 35 millimeters in total. Okay, right? We put this, and then what we tell the patient, we tell them close the eye, right? Close the eye, right? Close the eye, and this is still here, right? This is still here, right? What will happen, guys? We wait for 5 minutes. We wait for 5 minutes, right? What happens along this filter paper? The tear, right? The tear starts seeping in. It starts seeping in, right? So it will, the liquid will start, the tear, the filter paper will start getting wet, right? It will start getting wet and moving downwards little by little, little by little. Okay. Now, just from these two tests, which one do you think is more comfortable for the patient? Which one do you think? Huh?
The Sherman's test.
Why?
It doesn't have to open the
Yeah,
eyes.
we let him close the eye, right? We let him close the eye. So especially for a patient who is having dry eye, it's going to be more preferable. He's going to prefer that more as opposed to keeping his eye open and burning and dryness and all of that, right? So that is another reason why we usually use the Sherman's test, right? And what is another reason why we prefer the Sherman's test, guys? Because the eye is closed. In the TBUT, right? In the tear film breakup time, since the eye is open, other factors can come into play, guys. For example, if there is a gust of wind going about, right? If it is an open clinic and a gust of wind is going about, that also can affect the tear film breakup time, right? Humidity of the clinic, right? That also can affect. Whereas the Sherman's test, not really, right? Since the eye is closed, it's much better. It's much better, right? So this is why we prefer this. Now, after 5 minutes, guys, this we do it for 5 minutes. We do this test for 5 minutes. We do this test for 5 minutes. After 5 minutes, we are going to assess how far this tear has reached, right? In the filter paper, right? This is what we are going to assess. Normal range, guys, in a normal person, right? It is going to be more than 15 millimeters, right? More than 15 millimeters in a normal person after 5 minutes, right? Then, guys, if it is dry eye, usually it is less than 5 millimeters. This is indicative of dry eye, right? Less than 5 millimeters. Anywhere from 5 to 14, guys, this is, we say, borderline. Borderline. So there can be a defect in the eye, or maybe just that day that patient is having some sort of a small issue, right? Or maybe there is some environmental change, or there can be a tear, the filter paper itself can have some problem, right? So it can be multiple issues, but if it is less than 5, right, it is almost always dry eye. Okay, normal patient will have more than 50. Okay, right? So that is the preferred one, guys, Sherman's test. Then we have another test again for the eye, guys, right? This is called rose Bengal staining. Rose Bengal staining. What is this? Right? Rose Bengal staining. This is an agglutination test, guys, right? What do we do? Now you all know normally in a normal person's eye, we have a nice tear film of 3 layers, right? The tear film is there, right? What is there in a Sjogren's patient, guys? The middle aqueous layer and the inner mucin layer is going to be reduced, or in the case of severe disease, it can sometimes even be absent, right? And irregular, right? Not evenly spread across the eye, right? What we do, guys, we add this, we take, I mean, we don't take the eye, we leave the eye there, right? Okay, and we add a few drops of this rose Bengal stain, right? It's a red color stain. We add a few drops of this rose Bengal stain, right? In a normal person, guys, in a normal person, what happens in a normal person? You all know the tear film is intact, right? Tear film intact. So therefore, will this rose Bengal stain come into direct contact with the epithelial cells of your eye, with the epithelial cells of your conjunctiva? Will it come into direct contact?
No.
No, no. That is what we talked about. Those three layers of the tear film, they prevent direct contact of outside substances. So what is happening, guys? You put this rose Bengal stain in a normal person, you will put it from this lateral corner, and it will eventually flow out, and it will come here, come out of that, right? And after a while, the the eye will just be looking as good as new, right? No staining, nothing. But what happens in Sjogren syndrome when you do this, guys? You all know the tear film is defective, right? Therefore, some areas of the conjunctiva will be directly exposed. Those areas, those epithelial cells will take up the stain, right? The rose Bengal stain will be taken up by those epithelial cells, right? And depending on the severity, guys, right? The conjunctiva will be stained, right? Depending on where exactly those where the tear film is defective, the conjunctiva will be stained, right? Because the epithelial cells take up the stain because they are in direct contact now, right? Now, I put a picture here. Look at this, guys. These are positive tests, right? These are positive tests, right? After staining, the rose Bengal stain is going to stay there for a while. Okay, right? Okay, right. So those are for the eye, guys, for the eye, right? Then we come to this lip biopsy, right? Okay, lip biopsy. Here, guys, what do? We usually, now tell me this, if you look at the minor salivary glands and the major salivary glands, which ones do you think are more exposed? Where more outer and easy to, we have on the lips, the minor ones, we have on the lips, we have just underneath the cheek. Whereas the major ones, where they are in deep tissue spaces, guys. Okay, the major salivary glands, they are a little bit more deeper structures. So when we are doing biopsies, we prefer to not go inside. We prefer outside things as much as we can, right? To prevent secondary infections and complications, right? So the preferred one is the lip, guys, right? So we preferably take the lip biopsy of the minor labial salivary glands, right? This is what we prefer. And this one is, guys, this is the gold standard for the diagnosis of Sjogren's. Okay, lip biopsy. Lip biopsy is the gold standard for the diagnosis of Sjogren's. Okay. Now tell me this. What will you see in the lip biopsy? Based on our pathophysiology, what will you see?
Infiltration.
Sorry, yeah, lymphocyte infiltration. So y'all can write that down, right? Lymphocyte infiltration. Predominantly what? Predominantly CD4 plus predominant. CD4 plus predominant. Apart from that, guys, you will see plasma cells also which have come to that area. You will see macrophages due to the inflammation, all that we will be seeing. But just remember, lymphocytic infiltration will be there specifically CD4 plus predominant, right? Don't forget that, right? CD8 also can be seen, but predominance is CD4 plus. Okay, right? Then, guys, apart from that, now we drew a structure of a salivary gland, right? It looks something like this, and the duct was there. When there is inflammation, guys, you will also see this ductal wall, it swells up, right? The ductal wall swells up and there can be obstruction to the flow, So that is another thing you can see on histopathology, right? The inflammation giving rise to swelling of duct wall. This also can be seen under the microscope, right? But the main thing, don't forget lymphocytic infiltration. It comes in question, lymphocytic infiltration, very important, right? I did not come across a question where they have included, where they want you to differentiate between HIV and Sjogren's, right? I did not come across such a question, but just know it in case one fine day it comes, right? CD4 plus versus CD8 plus, right? Because if you look at Kumar and Clark, if you look at Harrison's, they have clearly mentioned that difference. So very important. Right. Then, so that is the gold standard. Don't forget that is the most diagnostic. Right? But it is usually not the first test that we do, guys. Okay? It is usually not the first test that we do because it's a biopsy. Right? More than that, we can do something like a Shermer's test, right? We'll see. Right? I will teach these with the questions. Then we come to the full blood count, FBC. What will we see? Just like SLE, guys, similar picture, right? RBCs can be low, WBCs can be low, platelets can be low, thrombocytopenia. ESR can be elevated, right? CRP can be normal or high normal, right? Not very specific, right? Similar picture to SLE, similar picture to lupus, right? Now, why is the ESR high here, guys? Why is the erythrocyte sedimentation rate high here? Inflammation, yes. Can you be a little bit more specific with regards to the plasma cell activity? Anything comes to mind? We talked about this in SLE as well. Same mechanism. Why?
Increased blood viscosity.
Why? Good. Why?
Due to the
antibodies.
Yes, so much of antibodies are being produced, right? So much of immunoglobulins are being produced, right? You all know these immunoglobulins, they're sticky, right? They're sticky in nature, right? So much of immunoglobulins are being produced. Therefore, they tend to increase agglutination and the viscosity of blood increase, right? So erythrocyte sedimentation rate can increase. Apart from that, other inflammatory cytokines also can play a role there, right? But no, just that because of hyperglobulinemia, right? Immunoglobulins are going to be increased, right? Then we'll come to the serologic markers, guys. Again here, right? Similar picture to SLE, but there are some specifics, right? ANA can be positive, guys. We said even in SLE, majority of the patients will have anti-nuclear antibodies, right? It is highly sensitive, right? But it is not very specific. Even Sjogren's can have, right? A lot of autoimmune conditions can have ANA positive, right? So this one is highly sensitive, but not very specific. Anti-Rho, anti-La is much more specific for Sjogren's. It's much more specific for Sjogren's, right? We have talked about this, about the Rho proteins and the La proteins, right? Here, about the anti-Rho, anti-La, what is the important thing I want you all to remember, right? The complications, specifically in pregnancy, guys. In pregnancy, right? If anti-Rho and anti-La is there, it can cause what? Complete heart block in the fetus. Complete heart block in fetus, right? And sometimes it can give rise to a neonatal form of lupus, right? Neonatal lupus can be either of the two. Now, anti-Rho and anti-La is specific, guys. It's much more specific than ANA, but still, not all Sjogren's patients will show it, right? It's about 70 to 80% of Sjogren's patients will show it, right? But not everyone. Sometimes there are anti-Rho and anti-La negative Sjogren's cases as well. Okay, right? But for the most part, we get anti-Rho and anti-La, and for your theory papers, of course, they will give it, right? Right. Hyperglobulinemia, this is what we talked about. Immunoglobulins are going to be high. The autoantibodies, right? basically our gamma globulins. Sometimes, guys, rheumatoid factor can be there, right? You can write sometimes, usually, right? Sometimes, right? Sometimes rheumatoid factor is positive, right? It is common, right? It's not a rare scenario. Now, what is rheumatoid factor? What is rheumatoid factor? How would you define it? No? After learning rheumatology, if you all don't know what is rheumatoid factor, what is rheumatoid factor? Answer. Guys? Yeah, I don't know if it's a network issue or you all don't know the answer now. What is rheumatoid factor? How do you, let me ask someone who is here. You all are not showing your faces, no guys. Turn your cameras on. Only 3 cameras are on. Janani Amaratunga, are you there? Behind the camera. What is rheumatoid factor? No? Shashank, what's rheumatoid factor?
And their antibody
Yes,
protein
it is an antibody against what?
own cells, like
Be a bit more specific. Antibody against IgG, correct? Antibody against the FC portion of IgG, right? Don't forget these are very important. Rheumatoid factor is an antibody against the FC portion of IgG, right? FC portion of IgG, right? This is rheumatoid factor. Now, here's what I don't want you all to confuse, guys, right? We say rheumatoid factor can be positive. Does this mean the patient will have hypoglobulinemia? What do you all think? No, why? Now we are saying the patient has hyperglobulinemia. We are saying immunoglobulins are going to be high. But at the same time, we are saying some of them can be rheumatoid factor positive. That means, so out of these immunoglobulins, you all know there are various types of IgM, IgG, IgA, like that. If their rheumatoid factor is positive, that means what happens? IgG subtype is going to be reduced, right? IgG subtype is going to be reduced, right? But still, guys, even though if the rheumatoid factor is positive, true, a little bit of IgG can be reduced, but overall, if you look at the immunoglobulin count, it is still going to be high. Okay, don't confuse this. In questions they give, right, Sjogren's, right, for they can give you the answer as hypoglobulinemia, right? Given they will give you a history with rheumatoid factor positive, right? True, IgG can be reduced, right? But overall, there will be such a large amount of immunoglobulins being produced that the total immunoglobulin count won't be affected. Hyperglobulinemia will be there, right? Hyperglobulinemia. Okay, don't get that confused, right? Then sometimes, rarely, guys, we can have this anti-mitochondrial antibody as well in Sjogren's. This is not very common. It's quite rare. And if it is there, this is going to be severe disease. Okay, severe disease. Just know that, right? Because your body's mitochondria are going to be destroyed, right? Okay, just know that. Okay, right? Is that clear? Right? Then, guys, finally, we come to the management, right? What can we do here? Read this sentence. There is no disease modifying agents up to date, right? Today. So it's up to you all. Maybe you all can someday find out, right? discover and call it your drug. Put your name in front of it. Therefore, what is the thing, guys? Treatment is you manage any underlying secondary cause, or as we said, right? We can have underlying associated illnesses like SLE, scleroderma, rheumatoid arthritis. You manage those underlying causes. And for the Sjogren's, it's basically symptomatic management. Symptomatic management. How do we do this? Right? Let's take a look. Right. Let's take a look here, guys. Symptomatic management of Sjogren's. How do we do this? First one, you all can write down management of glandular manifestations. For the glandular manifestations, what can we do? Right? Basically, we are talking about the dry eye and the dry mouth. Right? Look at dry eye first. Dry eye. Dry eye. What can we do here, guys? Right? One of the first ones, guys, one of the first options, the first lines that we use for dry eye is artificial tear replacements, right? Artificial tear replacements, guys. These are just drops. Here I have put a picture for you all, right? These are just preparations, right? Basically, artificial tears. They can contain some forms of mucin, right? They are basically made in the laboratory, right? Artificial tear replacement. This is the mainstay. This is the mainstay, right? Artificial tear replacement. This is the mainstay of therapy for dry eye. Apart from that, guys, what else can we do? Another approach is, guys, tear preservation. Tear preservation. What do we mean by this, guys? Whatever, now let's say the patient who is having dry eye secondary to Sjogren syndrome, they have a problem in tear production, right? Tear production. But whatever tear produced, we want to preserve it as much as possible, right? That is this tear preservation story. How we can do this is, guys, we can, depending on the severity, right? We can suggest the patient to wear glasses without the lens. Without the lens, they don't need the lens. They don't have a defect in their vision, right? Just glasses. Sometimes you all might have heard something called cooling glasses, right? You all wear to protect yourself against these screens, right? Laptop screens, computer screens. You can suggest them to wear something like that. That prevents drying out, guys. It prevents wind directly coming and hitting the eye, right? So you can say something like cooling glasses. Cooling glasses, we call it, right? No lens, no need a lens here. Apart from that, guys, soft contact lenses. Contact lenses. Now, this is a little controversial, right? It depends on the patient's affinity. Some patients, guys, they cannot wear contact lenses, right? When they wear, the irritation increases. So for that kind of a patient, we don't suggest this, right? We can ask them to try it out and see, right? Soft contact lenses. Apart from that, guys, there is another one, nasolacrimal duct occlusion, right? Okay, what we do here, guys, there is a device called a punctal plug. Okay, I put a picture for you here, right? This is a punctal plug, guys. What do? We insert this small plug into the punctum, right? Into the punctum, and that will prevent the tear drainage into the lacrimal drainage system, right? You all know the nasolacrimal sac, the nasolacrimal duct. It will prevent the tears going out of the eye, right? So it will keep the tear within the eye. Okay, this one, guys, it's a surgical procedure. You can't just put it in with your finger, right? It's a surgical procedure, and this can be temporary or permanent, right? There are different types of plugs, right? Some ones are temporarily installed for a few months. They can try it out, or they can be permanent as well. Okay, these are called punctal plugs. Punctal plugs, right? Right. Then the next approach we can try is, guys, tear stimulation. That means what? Now, we did tear preservation. Whatever was produced, we tried to preserve it. Now, if that production is also so less, we can stimulate the tear gland. We know that the tear gland is undergoing inflammation and damage, but we can stimulate whatever active cells to produce more tears, right? How do we do this, guys? What is the drug here? Pilocarpine, right? You all know about this drug. This is a cholinergic agonist, right? Cholinergic agonist, right? It's the opposite of anticholinergic. So basically, what does it do? Increases secretion of exocrine glands. Exocrine glands. There can be, remember, with pilocarpine, there are other side effects, guys, right? In pharmacology, you all must have studied, right? So you have to watch out for those. Here, guys, the pilocarpine, should we give it as eye drops or should we give it orally? What do you all think?
Eye drops.
Okay. Anyone for oral?
If it's stimulating the glands, I guess it's going oral.
Yes. The main reason, yes, it's here's the thing. If you give it as drops, yes, you're correct, but it can still stimulate the glands as well. But the side effects in the eye will be much more higher. Specifically, you all know when you give pilocarpine, what happens to your eye, guys? Especially with regards to your muscarinic receptors, you all might have studied, right, in your third years and all. Your iris sphincter muscle gets contracted, right? Ciliary muscle contraction. What is happening? Meiosis, right? Your the contraction of the sphincter muscle, right? They are going to make your
Pupil.
pupil smaller. Yes, the word wasn't coming, right? Had a bit of a brain fog. Thank you. Right? The pupil smaller. The pupil, right? Your pupil is going to be smaller. Right? So because of this, guys, we prefer oral pilocarpine, right? Because in oral pilocarpine, this effects to the constriction of these muscles will be much less. It will be much less, and the gland action will be much better. Okay, right? And then, guys, what I want you all to know, right? This is the mainstay. These options, guys, we almost never use. Almost never. Very, very rarely do we need to go for these, because in Sjogren's, just the tear replacement is usually enough. Unless they are suffering from other underlying causes like severe lupus, right? Severe rheumatoid conditions, scleroderma, whatever. Then yes, the dry eye might be severe. Otherwise, usually the tear replacement is enough, right? Very rarely do we need to go for these drugs, right? And the other surgical procedures. Okay. Right. Then, guys, dry mouth. What do we do about dry mouth? Right? What to do about dry mouth? What do you do when you have dry mouth? What do I do when I have dry mouth when I'm teaching?
Dehydrated.
First thing, water. Write it down 3 times. Water, right? Try to tell the patient to take in more water, especially if he's not drinking enough water. Usually there are some people like that, no? Right? Tell them to increase their water intake, right? And apart from that, guys, dry mouth means what now? The salivary glands are not releasing enough of the saliva, basically. So what we can do, we can stimulate this. We can stimulate the production and release of saliva. How do we do that, guys? Sugar-free chewing gum, right? Why sugar-free? Because Sjogren's is a chronic disease. If you get the person addicted to always eat chewing gum, right, with sugar, right, he might end up with diabetes, right? So sugar-free chewing gum, or sometimes even lozenges, right, they can help stimulate, right? Stimulate the salivary flow. Right? Stimulate salivary flow, right? Sugar-free chewing gum. Right? Again, guys, there is a place for pilocarpine oral like before, but not commonly used, right? Pilocarpine oral, right? Not commonly used. Just remember, when there is dry mouth, what did we say, guys? the patient is more prone to dental caries and things like that, infections. Apart from that, sometimes, right, especially when the oral mucosa is very dry, there is a high risk for fungal infections, guys, for fungal infections, specifically of the oral mucosa. The common one is, guys, oral candidiasis, candida, right? Candidiasis, right? Oral candidiasis. In the case the patient has oral candidiasis, right? How can you treat it? How can you treat it? Right? These are usually minor forms, guys, not very severe oral candidiasis. Huh? Yeah, generally minor forms. But what you can give is clotrimazole, right? This is one of the best ones. Clotrimazole, guys, we can give lozenges, huh? Lozenges, right? There are clotrimazole lozenges, right? Okay. If the patient is having oral candidiasis, right? Apart from that, guys, another one related with the dry mouth manifestations, what we talked about, parotid swelling, right? This is due to the inflammation. This is due to the inflammation, parotid gland swelling. Now this one, guys, there is literally nothing we can do, right? Literally nothing we can do. They say you can apply some local warmth, right? Using a small cloth, you can dip it in some hot water and you can, keep it in the parotid area to relieve some of the pain, right? You can do, just write that down, local warmth, right? That is all we can do to the parotid swelling. But what is the important point I want you all to know here? If it is persistent, what is it? Rule out lymphoma, okay? If it is persistent, rule out lymphoma, okay? Because parotid swelling in Sjogren's, it's a recurrent form. It comes and goes, right? Okay, right. Okay, then apart from this, guys, specifically, right, for the female patients, right, if they are complaining of dyspareunia or vaginal dryness, right? Okay, vaginal mucosal dryness, right? You can suggest lubricants, right? There are estrogen creams, guys, right? Estrogen creams, right? Estrogen creams, if you are prescribing, can you prescribe it to any age group? What do you all think? Now you all know, so estrogen is also going to be in a balance in your body, right? So estrogen creams, guys, when we are prescribing for this vaginal dryness, we specifically prescribe this, right? Especially for postmenopausal people, postmenopausal females, right? We don't recommend prescribing estrogen creams for pubescent or reproductive age, females of reproductive age, right? Because then there can be an estrogen imbalance, right? Which can cause other problems, right? And you all know autoimmune conditions also have a relationship with estrogen, right? Okay, we talked about this in SLE. So we do not want to cause an estrogen imbalance. Therefore, in postmenopausal females, it's okay because already they are having a reduced estrogen level, right? And also here, guys, in vaginal dryness, again, watch out for yeast infections, okay? Watch out for yeast infections, okay? Right. Then apart from that, okay, we'll talk a little bit more about the other treatment protocols that we have. Right, these ones we have already talked a few of them, guys, in previous chapters. Other extraglandular ones, right? You have to basically manage any other underlying pathology that's going on. If it is arthritis, if it is rheumatoid type arthritis, if it is an inflammatory arthritis, what is the basic treatment, guys? I don't want doses. I don't want doses. How do we usually treat rheumatoid arthritis? Sorry,
Steroid.
what is the first line? We give some acetaminophen, NSAIDs, right? Non-steroidal anti-inflammatory drugs, right? Go through your notes, go through your notes. Then yes, there is a place for hydroxychloroquine, right? We talked about even in SLE, we have a place for hydroxychloroquine, right? Or sometimes, if, depending on severity, methotrexate, prednisolone, right? Corticosteroids, right? We can use all of these. Just write those down, go back to your chapters and write, because you have to manage these underlying causes, guys. When the patient presents with Sjogren, managing just the Sjogrens is not enough, right? Anything underlying, you have to manage, right? If it's SLE underlying, manage the SLE along with the Sjogrens, right? What about this Raynaud's, guys? Raynaud's phenomenon. What can we do for Raynaud's? What can we do for Raynaud's?
Vasodilator.
No, we don't. We don't usually prescribe vasodilators. Why? That can form further complications in the cardiovascular system, right? Unnecessarily. Raynaud's, guys, it's again symptomatic management, right? We tell them cold protection gloves, right? Cold protection gloves, right? Cold protection gloves, right? And unless there is Raynaud's syndromes, there are some Raynaud's syndromes where the Raynaud's is coming alone, right? There are different managements for those, right? But for these cases, because the autoimmune condition is giving rise to the Raynaud's, right? We don't usually try to give any vasodilator or anything like that. Okay. Then for renal tubular acidosis, again, you all can go back to your notes. But basically, guys, what is the treatment protocol here? Bicarbonate replacement. Bicarbonate replacement. Okay, bicarbonate replacement. Right, sodium bicarbonate usually, right? We can give them orally to take. Right. Okay. If the patient has lymphoma, this is in our next module, right? We'll talk about these. Just remember, there is a treatment protocol called CHOP. Anyone knows this? CHOP? What is CHOP? What is CHOP for lymphoma? Okay, no need to write it down. I will just mention, don't write it down. We'll talk about this in the next module. Cyclophosphamide, hydroxydonorubicin, oncovin, right? You all must have heard, another name is vincristine, and prednisone, right? No need to write down, don't worry. We'll talk about this we have to talk about the pharmacology and how they work in the next module, right? That's about it, guys. That's about it for the class. Let's go do some questions quickly, right? Do review SBA question number 1. Send the answers in the chat, right? These are very easy questions, guys. Sjogren's, you will see if you go through USMLE, if you go through PLAB, if you go through even ERP and the Sri Lankan examinations, questions, first thing, very low yield topic, right? You don't get a lot of questions. And even when you get, they're not very difficult. Okay, not very difficult. They don't make it too complex. Although the disease pathogenesis is still unclear, they don't make questions very complex, right? Asking you to try and figure out, right? Just okay, you all have already, okay, you all are already sending, okay, right? Okay, good. Yeah, okay, right. So the first one, patient with Sjogren's, right? Increased risk for which of the following, right? You all can put all of the above, no problem, right? Diabetes insipidus, right? Specifically nephrogenic. If they had given cranial, that's wrong there. If they had given cranial, that's wrong there. Okay, right. Number 2, quickly. What is the answer? Right, good. Yeah, Tarinder, sometimes when you click an answer, you should not change it later, right? Okay, sometimes the first click is correct, right? Sharud, think again. Look at these guys. Okay, which of the following has the highest diagnostic specificity for Sjogren? A lot of students, good, huh? Y'all are getting Shashank, Kiara, good, right? Yeah, Panchali, good, right? The answer is, guys, E, right? Both A and C, right? Lymphocytic infiltration of on the biopsy is highly specific. Anti-Rho SSA antibodies is also highly specific. It's also highly specific, right? Okay. We usually consider both of them, right? Very good, right? The gold standard is the biopsy. The gold standard is the biopsy, but both of them are very highly specific. Okay, right? Right. Go to question number 4, guys. Is very easy. Now, after doing the chapter, it's of course very easy. Huh? Okay, right? Yeah, right. I shouldn't have put this question, but it was from a past exam paper, so I just put it there, right? Yeah, right. Okay, everyone's getting it correct. Good. This is primary Sjogren's, right? Let's not even spend any time on it. Go to question number 4. Question number 4. Okay, let's try question number 4. Good. Tarin, the good. Sharud, good. Panchali, good. Good. Ella, good. Wait, did you all read the question so fast? You're a fast readers. Huh? Good. Tiara, good. One more answer. No? Right. Good. Okay. Look at this. 60-year-old female complains of dry mouth and a gritty sensation in her eyes. Word to word. This is how it comes, guys, in questions, right? She states it is sometimes difficult to speak for more than a few minutes. There is no history of diabetes mellitus or neurologic disease, right? Why are they giving you all this diabetes mellitus story here, guys? What do they want you all to exclude? They're basically, guys, because you all know in Sjogren's, right? In Sjogren's, we get renal manifestations and ocular manifestations, right? They're trying to tell you there is no diabetes to try and exclude diabetes, retinopathy, nephropathy. Okay, that's why they're giving that information to you. Okay, or no neurologic disease. The patient is not on any medications. That is what they're trying to tell you. He's not on any anticholinergics, basically, right? Okay. On examination, the buccal mucosa appears to be dry and the salivary glands are enlarged bilaterally, right? Bilaterally, right? Which of the following is the best initial diagnostic step, right? Lip biopsy, guys, this is the golden standard, right? This is the one of the best, but it is not the initial. It's not the first one. We don't usually do a biopsy as soon as the patient walks in, right? IgG antibody to mumps virus detection. Why are they giving you all this? Because they say buccal mucosa appears to be dry and the glands are enlarged. You all know when you have mumps, right? Especially these parotids, right? They enlarge a lot. Right? And mumps, guys, is not necessarily always bilateral, right? Sometimes unilateral, right? And then after another week, this side will swell up, right? It's like that, right? Not a week, 2 to 3 days, right? That's how mumps is, right? Then use of corticosteroids to assess response, right? Not very important. Assess administration of benzodiazepine. Why is this option here? Why is this option? Juniors, I don't expect you all to know. Seniors, interns, why is this option here? Administration of benzodiazepine. Let me ask the seniors. Who is here? Panchali. Who else? Tiara. Right? Why is this option here? Can you venture a guess? Look at this, guys. There is something, have you all heard, called alcohol withdrawal syndrome, right? In alcohol withdrawal syndrome, guys, especially these chronic alcoholics who are 99% of the time they're having hepatitis as well, they are accompanied by parotid gland enlargement. Chronic alcoholics, guys, they tend to have parotid gland enlargement. Okay, you should know this, huh? Parotid gland enlargement. When there is parotid gland enlargement, and this is so when they're having this alcohol withdrawal syndrome, when you give benzodiazepine, guys, benzodiazepine reduces the manifestations of alcohol withdrawal. For example, these seizures, right, difficulty in sleeping, insomnia, these kind of manifestations goes down when you give benzodiazepine, right? So what they're trying to confuse you with is that this case, since they just talked about the salivary glands enlarged bilaterally, they're thinking you will think that this is alcohol withdrawal syndrome. Okay, right? So that's why that option is there. Okay, so when you give benzodiazepine, manifestations of alcohol withdrawal reduce, right? So that helps in the confirmation of the diagnosis in alcohol withdrawal syndrome, right? Anyway, for us, the best initial diagnostic step is the Schirmer test, guys, and the measurement of autoantibodies. Specifically, we are looking for anti-Rho, right? Anti-La also can be there. Anti-Rho is a little bit more, even more specific than anti-La. Okay, anti-Rho is more specific. Right, last question. Right, last question. Yes, it's easy. Right. Good. All right. So this one, guys. So everyone's getting the answer correct. So I'm assuming everyone knows the answer is B. Which of the following is not helpful? Schirmer's test, guys. Usually, if it is more than 15, it's usually normal, right? ANA positive can be there. Anti-Rho is good. Elevated ESR can be there. Increased serum IG can be there. IG can be there. In immunoglobulins. Okay. Right. So that brings us to the end of the rheumatology module. Okay. So that's about it, guys. We will see all in the so we will be putting the restream notice out very soon, possibly this weekend. Y'all can all join for free. Just register for free. We'll put a separate Google form for y'all, like the previous modules. Right. That's about it. And the question discussion sessions, guys, Sasanga and Shan, they will be having it in the midst of the restream. In the midst of the restream. And this time's restream, we will be giving it for a little bit of a longer period of time, because we know you all are having your exams coming up, right? So we will be giving it for a longer period, about 1.5 months. There is like 16 sessions, right? 16 or 17 sessions. So 1.5 months is sufficient, we are hoping, right? So that's about it, guys. If you guys have any questions, right, drop me a message, or with regards to Shan's or Sasanga's chapters, you all can drop us a message, right? Get your doubts cleared out, right? We hope you all learned rheumatology well. Okay, right? So that's about it, right? See you guys in a future module, upcoming module, hematology. Okay. See you.
Thank you so much.
Right, no problem. You're welcome.
Bye.
You're welcome. Come.
Thank you so much.
Right, you're welcome. No problem.